Good morning. Okay, Rajneesh, am I live?
Yes, sir. Start to
Good morning. Good morning, Gianluigi. Good morning, Daniela.
Good morning, everyone.
Simon and Prashant. Sorry about the music this morning.
The first bar of Fairleys.
Yes, I'm so sorry.
Over.
I don't know what happened there.
We didn't.
Well, listen, for those of you who survived that little introduction, good morning to everyone. Good afternoon, good evening, good night, wherever you are all around the world. Thank you for joining us to another fantastic program of Scan Academy today. We've got some brilliant speakers lined up as usual. We will be talking today about the posterior fossa. Let me just very quickly share a couple of slides just to point you in the direction of one or two other things. Thank you. So we're going to be covering the posterior fossa today. We're going to start with Prashant, who will be covering embryology and early anatomy. Simon, who will be talking to us about what's feasible in the first trimester. Gianluigi will be talking us through the nomenclature, the normal development, the abnormal development in the second trimester, which is when most of us see these abnormalities. And Daniela Pryor from Vienna, who will be joining us to talk about what MRI can contribute to the diagnosis. I will not be speaking today. I'll be moderating. I'll be taking your questions. I've got my other screen open here. So please send your questions to our experts, and I will be moderating the session. If this is an area of interest to you, please have a look. There are 2 papers that we've previously written. They're from 2016, but they're still very much current, which are both systematic reviews. So they review all the literature around isolated posterior fossa malformations. They're available in ultrasound and obstetrics and gynecology, easy to find. Just put ultrasound obstetrics and gynecology posterior fossa and one of the names of the authors into Google, and you will find it. There are 2 parts to the systematic review. The second part concerns itself with neurodevelopmental outcome. So that's just as a background. They are freely available, and you just have to click on the link. There's no paywall or anything like that. I will start with Prashant, who's a dear friend, previous ISWOC board member, previous FOGSI board member, chair of the Genetic and Fetal Medicine Committee of FOGSI, vice president, and many other accolades. He works as a consultant in fetal medicine and high-risk obstetric care, and is an expert, for those of you who haven't met him yet, in fetal imaging. But he has particular interest and particular skills in how we can use ultrasound together with histopathology in learning about the anatomy of early human development, and is a fantastic teacher. So I look forward to seeing how the early part, how the posterior fossa develops, and I think that understanding of anatomy will be a good background for the subsequent talks. Thank you, Prashant.
Very good morning, all dear friends across the globe, and I welcome Dr. Gianluigi Pilu and Daniela for the first time with the SCAN Academy. Welcome, sir. I'll share my views about how the fetal embryology, particularly with the posterior fossa, develops. And this is what is really very interesting. The moment you understand the embryology, the moment you understand early anatomy, I think it will be easier to understand what are real pathologies. And if you understand real pathology, it becomes very vital to counsel the patient what is going to be the outcome and what kind of investigation you will need and what kind of follow-up you will need. This is one slide which gives you one clear idea about from 7, 8, 10, and 12-week gestation of the embryology of posterior fossa. But we'll discuss this everything right up in details like this. And thank you, Aris, for my introduction. These are the few slides. This is one typical grayscale image which we also.
Can you start a PPT again? We lost a PPT.
Okay. Is the PPT there? Adnan?
Please share again.
I'll share again. Is it okay? Hello?
So go ahead, sir.
Thank you, Prashant. I'm also having a couple of messages from 2 people who are not able to hear. We've got almost 3,000 people live right now. So if you're unable to hear on your device, please refresh or maybe log in again, because it seems that everyone else is able to do that. And I will leave a message as well.
Is it okay all right now? Shall I go ahead?
It's fine.
Yes, Prashant, we can see.
Okay. Now this is about embryology of posterior fossa. You can see on this slide, right from the development of from 7 weeks, 8 weeks, or 9 weeks, or 13 weeks. The moment you understand the embryology of the posterior fossa, you will understand what kind of malformations which are there, what kind of outcome this is going to have, this fetus outcome, and what exactly counseling what is required if you understand the embryology and anatomy. Thank you, Aris, for introduction. I'll go straight forward. This is a grayscale image on your top right bottom corner. That's what we are used to see the posterior fossa in a grayscale. You zoom it mid-sagittally, you'll have this kind of vermis, but some kind of malformations. The first trimester evaluation of the posterior fossa has a new interest now. Comparing the anatomy and what kind of outcome these things are, we'll discuss every point in detail. Some of the posterior fossas, this is what the area which we are primarily interested in looking for, and that's what we will be looking for. Now, as far as the anatomy is concerned, this is one typical fetal brain. From external surface, you rotate, you will find your sulci and gyri, and this is the inferior surface where these are the two cerebellar hemispheres. This is the typical portion of the vermis, and this is the tentorium cerebelli. So you need to understand vermis, you need to understand the relationship of the tentorium cerebelli. The moment you understand the relationship of tentorium cerebelli with vermis and the cerebellar hemisphere, it will be easier. This is a gross specimen. If I cut the same specimen in the mid-sagittal plane, this is where we are interested in knowing what kind of systems. The images, what we see on ultrasound is this section. What you find is a typical mid-sagittal is a corpus callosum, the interthalamic adhesion. This is, if you really look at this, that's an aqueduct. This is the choroid plexus of the fourth ventricle. This is the fourth ventricle, and this is the typical all vermis, and these are all segments of the vermis, and this is what exactly we are looking for in the second trimester. You've got, and this is just one graphic representations here, picture of MRI. But look at this. This is a 14 or 15 week of brain. Look at the difference. Sulci gyri, flat brain, only one little bit of depression which is there. But look at the posterior fossa here. In this image, you have got only part of vermis which is there, and here the things are really very different. And this is what actually the development which we are looking for. 12 week it is different, 15 week it is different, 17 week it is different, and 25 week it is different. So posterior fossa, the cerebellum and the vermis, they actually develop. They actually develop still 24 to 26 week, and even after the birth they start growing. But the structural development is almost complete by the end of the second trimester. You have got a mid-sagittal section. You have got a gross specimen, two cerebral hemisphere, and that's a midline portion. That's what the vermis is going to be. Now, how this entire structure develops, this is where we'll be interested. And because there are all six major complications, six major malformations of the posterior fossa, which Dr. Pilu and Gianluigi and Simon and then Daniela Pry is going to discuss about all this, what we find out in second trimester, and how we should go ahead. This is a typical system where from these three vesicles, the entire fetal brain is developing: prosencephalon, mesencephalon, and dromencephalon. And from there, these are some graphics, but that's not important. But the same things which we can see even on ultrasound. CRL 10 millimeter, just 7 weeks. We all know that the three dromencephalon, mesencephalon, and prosencephalon, they all will be seen. The moment, no limbards which are seen, really very well seen. But this is what you can see brain at when the fetus is of 10 millimeter. This is CRL 14, just 4 millimeter increase in the size. You have got limbards which are there. It's not only the limbards, but most important point is you find three good vesicles where from this green area, from the dromencephalon, the entire posterior fossa which is going to be developed. And at 21 millimeter, just I'm adding some of the points at 21 millimeter, 7 millimeter more, you will find a very, very classical, the third ventricle, mesencephalon, you have got prosencephalon, two lateral ventricles, you have got aqueduct, you have got where your opening can be seen, and you have got a complete dromencephalon which is seen. If you take this is the same fetus, it's not different, same fetus which you will be able to see all different sections of the posterior fossa, and that's how from 7 weeks, 8 weeks, 11 weeks, and 13 weeks. Look at the third ventricle. It's going back, it's going here, it's going here. But look at dromencephalon, which was quite up, it has gone down, it has gone quite down, and this is quite down. So that's how there is a shift from anterior to posterior of entire system because the cerebellar hemisphere develops, it grows from anterior to posterior aspect, and that's the reason the posterior brain which goes further posterior, and that's how the anatomical structure repositioning is happening. Now, one typical thing happens at 7 weeks is instead of straight brain, there is a pontine flexor. The pons becomes little bit flex, and you have got this flexor which is developed, and that is which starts happening at 7 weeks, and that's where the entire system starts developing. At 7 weeks, in this pontine flexor, there are a couple of things which happens. And this pontine flexor, with the same image, I have just done one thing. I have just make it more transparent so that you can appreciate this pontine flexor. And when it is from a lateral side, when I rotate it posteriorly, it is going to be like this. If I rotate posteriorly, if I look at from the posterior aspect, you have got a typical third ventricle, aqueduct, you've got fourth ventricle, foramen of Magendie, and rhombic leaf, which are going to be developed. And that's how we'll be discussing those things, how these things. Now, if I take a volume sections at this point, I have drawn a color line right at the top. I will be seeing 2 lateral ventricles. I'll be looking at a third ventricle. I'll be looking at an aqueduct, and I'll be looking at a complete rhombencephalon. And the entire thing which develops, and this is a lateral aspect, this is a lateral view, this is a posterior view. So you can understand what exactly, there is a flexor which is going to be there, and that's covered with the roof of the lateral ventricle. And that roof, from the roof, it's about the system, with that complete system of the ventricular roof, the entire fetus cerebellum is going to be appearing. And this red, which I have seen, I have created a volume for your rhombencephalon for how these things are developed. Now, there are many parts of posterior fossa. One is cerebellar hemisphere, one is vermis, foramen of Magendie, cisterna magna, black pouch. The confusion about the black pouch, we will take it one by one. The development of cerebellum, one brilliant book. It's 9th edition of Langman's Medical Embryology. I have taken quite a lot of references from them, some of the images from them. So I'll share those, and I'll try to make you understand from that. A lot of precise control of the development by genetics, because many genes are involved, and there is a very precise control. And that's the reason now we have come up. We try to investigate these malformations with the basis of some of the genetic evaluation. We would like to pull out those things. Now, this is the same rhombencephalon, posterior aspect, anterior aspect. This is rhombencephalon with a roof of rhombencephalon, and this is again one of the lateral aspect. But the same section, we have got all 3 different sections from where the posterior fossa and the cerebellum is going to develop. We'll be taking that. As I told you that the pontine flexor, but that's an anterior aspect of the brain. When you look at the posterior aspect, this is the posterior aspect. This is the posterior aspect. There is going to be one transverse crease. When a transverse, if you cut it in a line, is going to see just like a tip. And this tip, the upper portion of this tip, which is known as membranous anterior, and this is going to be known as membranous posterior. And so this tip will divide into 2 segments. One segment here, one segment there. And that is most important, because the area above this ridge, from where you have got your development of cerebellum and the vermis, and the area behind this is from where probably you'll find the choroid plexus, which is going to be at that location. So from that ridge, you will have a bird which will be coming out from, that's where the choroid plexus, which is going to be there, and cerebellum is going to be developed from this interior area, and lower on. What happens? There is one typical thing which happens, that these, if you really see this red area, that primitova is a thicker structure. It's a complete structure, but then at some vacuoles, cavitation starts developing, and these cavitations, when you have got some bubbles, but when that bubble grows, between those 2 bubbles, this becomes very, very thin portion, and that trabeculation in a pia arachnoid septation, that's what we'll be able to appreciate right in your second trimester. So in second trimester, the anatomy is going to be a little bit different than what we see. Some kind of, from parasagittal section, you'll find some kind of septa is because of there. Now, from this membranous anterior portion, the entire portion of cerebellar hemisphere, which is going to be developed, but area below that, there is going to be a development of the cava, the choroid plexus. But look at this, one pouch which has started developing and which goes behind. And that is what is typically known as Blake's pouch. And that Blake's pouch, it's a normal finding. When that Blake pouch goes there and it fenestrates later on during the 8th, 9th, or 12th week, or occasionally it may delay till mid-second trimester. And from that fenestrated or that perforation which happens from that foramen of Magendie, which is going to be happening. So from that area, this is one very beautiful article which is Robinson have written. Ashley Robinson has given one crystal clear idea about how your posterior vernian development is going to happen. So that these are the two areas: membranous anterior, membranous posterior. From membranous anterior area, cranial side, the cerebellum and vermis is going to be formed. So caudal area, you will have a Blake spout, and from that foramen Magendie, which is going to be formed. Now, how can I put it into my ultrasound in my practice? Now, this red line that separates both the area membranous anterior and area membranous posterior. You will have cerebellum, you will have vermis. They all will be developing at this stage. So cutoff point is going to be your choroid plexus. Anything above your choroid plexus, they all are membranous anterior region. This is posterior, anterior, and posterior region. So that's what from that area you will have a development of complete cerebral hemisphere and vermis, which is going to be happening. So now going further. Now, if I remove the roof of the cerebellar hemisphere, the rhombencephalon, I'll find this kind of image, and you'll have the rhombic lip. If I now cut this section, or if I cut the rhombencephalon right at this area, this is going to make it transverse. Now, when it makes it transverse, you will have your roof and you will have base. And the base is known as LR plate, and that roof and the LR plate, this is what your roof is going to be. And from the roof, you have, that is typically roof of the rhombencephalic vesicle. You need to understand what exactly anatomical changes which are going to be happening. So two LR lamina does not touch each other because they are quite widely separated, and you have got a complete membrane in between there. Now, from these wide separation, one typical thing, let me explain you first, then you can understand it in graphics far better. So from separate, you'll have one projection which comes out. That is what is known as typical LR. This is going to be a lateral plate. This is going to coming together, and this rhombencephalic roof is going to be getting shorter and shorter and shorter. From this area, you will have the cerebellum and vermis is going to be developing. So let us understand this. What happens is from this area, you will have your rhombic lips. You will and the choroid plexus, which are going to be there. You will have a dorsolateral parts of the LR plate bends medially. That they are all known as rhombic lip. This is rhombic lip. You have got your area. Red line is going to be, that part is going to be a little bit smaller. And these two rhombic lip, they even grow closer, and the base which is there, which becomes a little bit longer. Because the base is a little bit longer, you will have these rhombic lips comes to closer together. So that closer, it usually closes, you'll have a choroid plexus which is going to be there, and these cerebellar plates comes together. You'll have the choroid plexus which is situated below, and that's what the closing happens. A rhombic lip which gets closed, and from this area you will have your cerebellar hemisphere which are going to be developed, and the middle area, the cerebellar vermis is going to be developed. Eventually by 12th week, you will be able to find, these are the 12th week ultrasound, this is histopathology specimen, autopsy specimen. You will have typical two cerebellar hemispheres which will be seen right there. Now there is one typical thing happens. You have got a plate. One area is lateral, one area is medial. From the lateral area, it is going to be the posterior part of the cerebellum which is going to be developed. And from the medial area, it is usually the interior part of the cerebellum is going to be developed because the granule cells, the movement of granule cells happens that way. And that's for, as the primordias are separate, there are possibility of some of the different kind of involvement of the different region of the vermis, and that's the reason you will find quite a lot of things which are going to be developed. A transverse fissure soon separates the nodule of the vermis and the lateral flocculus from the hemisphere, and these flocculonodular lobe, these gray line, that's a flocculonodular lobe, that's the most primitive part. And from that area, which red line, which I showed you previously, the entire cerebellum is going to be growing from that part. So further development of the cerebellum, cerebellar plate, which has neuroepithelial, mantle, and the marginal cells of number of cells which are formed by the neuroepithelium, which migrates to the surface of the cerebellum to form the external granular layer. That's what typically what we call as a molecular layer, and that's the reason. And that's the reason you have got a complete growth from a plate. You will have a complete cerebellar growth outside. This is what at 8 week at the histopathology would look like. 12th week migration per Purkinje cell, shape of 12th week, shape at 15th week. These are all graphics, but what exactly it does, what we can see on ultrasound, let us see. On 8th week, 10th week, it is always difficult to appreciate the level because there are too small a structure to appear by 12th week. But at 12th week, when you have at this gestation, you will find this typical of cerebellum. This is what the cerebellum is. And these are both hemisphere, and this is exactly what you will be able to appreciate. By 15th week, you will be able to appreciate not only this is the 15th week, you will have a typical vermis-like structure which will be there. You have got aqueduct which will be there. You have got, this is the cerebellar hemisphere. This is an aqueduct which will be there. This is a three-dimensional picture. This is what I can see that this is the 15th week cerebellum, and which you will be able to appreciate. So you will have a complete from flocculonodular lobe. This is what you are both cerebellar hemispheres which are going to grow. And from that, now there are three major parts. The most oldest part of is archicerebellum. This is what the archicerebellum, paliocerebellum, and cerebello or pontocerebellum. These are the three things and how they are all going to be developed. Now, 13th week, as I told you, as far as ultrasound is concerned, 13th week cerebellar hemisphere, you can appreciate cerebellar hemisphere too, which are going to be there. So you will have a posterior fossa at 14th week. This is what you will have a typical thing of I would put it across as a fourth ventricle. Aqueduct can be seen. You will have fourth ventricle which is seen. Choroid plexus can be appreciated, and Blake's pouch can be seen. So you can see everything right there. Looking at a video of that, and you will be able to understand how these things are. Now this is one important section where I have put it a coronal as well as sagittal sections together. Now when I move forward, this is from lateral side, coming right in the midline, going one side. So this is what is going to be the orange dot. If you see this orange dot, this is the orange dot. So this reference is, if you see, this is a typical 4D later on. So I am right now in the mid-sagittal section. Because I am in the mid-sagittal section, you will see a typical early vermis development. If I go on one side, still I go on one side, this is a typical of Vermeer, the cerebellar hemisphere, which is there. Again, going from the midline, going here, I can see both the cerebellar hemisphere here. When I go lateral, I should be able to see this. When I come right in the center, I should be able to see the entire cerebellar system. So looking at going right again there, 15th week, as I told you, this is typically, I think I've already shown it to you. Sorry for this, repeating this slide again, but let me show it that what happens. Now the growth of cerebellar hemisphere or the cerebellar neural fibers are even more than the cerebellum. So cerebrum is less fast growing than the cerebellum at the end because they are all confirmed by fetal MRI, and this is what a latest 2017 study, it confirms that kind of stuff. In second trimester, again a migration of these neuronal migration happens, and in the vermis and in the cerebellum, and this is what happens. Now, how from cerebellar hemisphere, let us understand how vermis is going to be developed. Not only that, as I told you, anterior and posterior aspect, lateral aspect, the central region, vermis is developing. Now, there are some different kind of systems which develops. They are all different than the cerebellar hemisphere. That's the reason we'll have to understand it separately. As the different segments are developed differently from the same region, but at a different time, and the segmental Vermean anomalies, that's the reason it is possible. If some segment, because it's not developed at the same time, it's developed at a separate time, and that's the reason if there is some insult, at that point when the development pauses, you will have some kind of different segmental development. Now, this is what typically you have got MRI pictures of 13, 15, 17, 19 weeks. You have got same vermis pictures. But 11th or 12th, 10th or 11th week, vermis enlarges superiorly. And hemisphere enlarged laterally. That's the reason there is quite a lot of gap between the developing cisterna magna and the fourth ventricle. By 12th and 13th week, the lobules and the folia of cerebellum proliferates, and the central part of the vermis develops, which is going to go further. Now, by 16th week, the opening of the fourth ventricle closes because the vermis grows down. And that's the reason the continuation which was there between cisterna magna and the fourth ventricle, now it will not appear like they are communicating with each other, because the vermis grows down, but which was superior, now it has start growing lower down. And that's the reason you will have a development of vermis. Is you have to remember one thing, it doesn't develop at the same time all the segments. That is one point. Second point, it first starts developing superiorly, then it goes inferiorly, and so the development is not previously, which was thought like this from anterior to posterior, but it is now in span manner. So you may find isolated vermian hypoplasia, and you may not find that. That's the reason you will have got a segmental anomalies of the vermis which are known. And that is the reason you need to understand about this, the development of the vermis. Now, typical thing is about the cisterna magna. Now, as you know, that cisterna magna is what? A cisterna magna is a black pouch which goes in the midline and it fenestrates. So this is what we see in the second trimester. You have got two septa. Middle part is usually, it's very clear because it contains pure CSF till the time it gets communicated. And you, as I told you previously, there is going to be the septation which is there in the lateral side, but the entire complex is known as cisterna magna. But the middle portion is practically a black pouch and the remnant of the black pouch. So if it doesn't penetrate, then it is going to consider as a black pouch cyst. As I told you that the obstruction of the foramen of Magendie, which doesn't happen, it will lead to obstruction, and that's what is going to be a black pouch and black pouch cyst. So instead of these foramen of Magendie, when black pouch doesn't fenestrate, that is what we typically known as black pouch. Now what happens is the black pouch? Vermis is developed. Both are developing from different area. Anterior membranous area is not affected. That's the reason you will have not a lot of problems of the fetal malformations which are going to be associated with that development in black pouch. Now, a clue to the diagnosis of the posterior fossa is that I'm sorry, this is one slide which I have come earlier. Clue to the diagnosis in the posterior fossa cysts are because of two things. I think I'll take it next. Let me start first. What is a normal development, which is going to be like this. So when you have got these fenestrated, I have already shown it to you, but these ultrasound can tell you about the cisterna magna. This is the black pouch, and that is what is going to be there. Now what happens with the pathology? When you have got the black pouch, it doesn't fenestrate. The cyst, it is going to rotate the cerebellum, and these cerebellum, which was quite balanced at both the side, instead of that, this is going to be pushed up, and that pushing up will lead to what? Instead of balanced cerebellum, if you cut this because of the black pouch, it is going to be tilted. And that's the reason that is what is typically known as mal-rotated. It is all because of the elevation. You will find some kind of communication which is here, and that's what is going to be elevation. It's not in the mid-sagittal section. One segment is going to be cut, not in the midline. It is going to be mal-rotated. So you will see these kind of things. As far as foramen Magendie is concerned, this is what I think you will be able to see: the choroid plexus, the black pouch, and this is going to get fenestrated, and from there, foramen of Magendie, which is going to be developed. Now look at this. This is a volume image which I've just gathered it yesterday, day before yesterday. You can see going through two lateral ventricles, going below. This is a third ventricle. Still, if I go below, it is going to have an aqueduct at this position. This is what the opening of aqueduct, and these aqueduct, which if I move forward, this is the typical shape of rhomencephalon, and this rhomencephalon, you have got, this is from where foramen of Magendie is going to be develop, and this is where you have got foramen of Luschka, which is going to communicate right there. If you take it, if you see it from posterior aspect or a lateral aspect, you will see a rhombencephalon, and this is what you will have, a foramen of Megendie, which is going to be developed right there. Now, the choroid plexus, as I told you, which is going to be right from the roof, which is going to be there. That's the first choroid plexus appears in the brain before the third and in the lateral ventricle. And absence of fourth ventricle is associated with, or the malposition of fourth ventricle also is associated with so many posterior fossa defect. That's a possibility, and that is what we will have to keep in mind, that the position of the choroid plexus, this is the position from posterior aspect, axial view, and this is a typical what we see in our mid-sagittal section, and that is what is going to be seen as a position of the fourth choroid plexus. Now, the problem with the position of these choroid plexus, I would like to tell you what could be the clue to the diagnosis in the cyst of the posterior fossa. Now, this is one typical thing, is there are two clues. One recent literature by Dario Palladini in 2018, they have come out with a possible diagnosis in the posterior fossa cyst is the size of the width of Cerevian aqueduct and the ponto-Vermian angle. So the ponto-Vermian angle is always going to be more than 100 degree. This is his images. Let us try about this. These are the recent capturing. So ponto-Vermian angle. Look at this ponto-Vermian angle. Look at this. Look at this. The dilated, and this is not dilated aqueduct. And this is what we should be able to see. And you can appreciate. I have taken a volume image. I will be walking through this. I'll just go through this. Parasagittal section, going right there, and almost about to reach to the mid-sagittal section. And when it reaches the mid-sagittal section, this is almost in the mid-sagittal section. You can see a right dilated aqueduct and a much enlarged posterior fossa with the placement of the choroid plexus, which is going to be really very important. And you should be able to identify that development is going to be, which is really going to be very vital. Now coming to one aspect. This is what I have already covered. Sorry about that. My time, I'm already done. Last 1 minute. Absence of choroid plexus in the fourth ventricle, which is also going to be very important, which will give you some clue about. This is one autopsy specimen of the posterior fossa cyst. This is normal, and if you can understand the cystic structure here in the brain, this is what you will be able to identify in the first trimester. There is one important slide which I want to share. This is the autopsy specimen, 12-week ultrasound, MRI, 16-week posterior fossa, 17-week, look at this. Look at the choroid plexus, look at the CC, posterior fossa, vermis, look at the vermis, complete fourth ventricle. That's how ultrasound also can create real beautiful images, actually like fetal autopsy specimens. Actually, what I mean autopsy specimen is a pathology. So use of ultrasound, use of good volume imaging, that is what I would like to make you understand, that first trimester ultrasound evaluation posterior fossa is vital. You cannot pinpoint the diagnosis, but definitely you can ask them to come for the frequent follow-up. Second trimester will confirm the diagnosis, and 3D, 4D is much in and helpful as far as ultrasound anatomy is concerned. A gene, Aladdin's gene, gene is going to be the use of 3D, 4D and neurosonogram, TUI, multiplanar imaging, render imaging is the master key in today's time. Thank you. Thank you very much for patient hearing.
Thank you so much, Prashant. Simon, I'm going to ask you to put your slides up just to make sure that they are working. So Prashant, thank you so much for walking us through how the folding posteriorly separates the different aspects of the relative anatomy of the plate pouch from the fourth ventricle and the cisterna magna. Very important. And I think this will become very clear also as we go through some of the clinical cases. Now, I'm going to wait for Rajneesh to give me a sign that we can see the slides. Are you sharing your slides, Simon?
Yes, Iris.
I can't see them.
So we can't see this. So please share the PPT.
Okay, can you see it?
Yeah, now we can see.
Just leave them on, please, for me, Simon, because I'm waiting. There's a little time delay, as you probably know, between us here as the speakers and the online system. So I'm just going to wait to make sure that we can see that. And in the meantime, I'll take any questions from you, Simon, to Prashant, or from anyone else. Prashant, you mentioned that there's certain clues to diagnosis in the first trimester, but is there imaging sufficiently? Can we get enough information from imaging in the first trimester to, for instance, make decisions around termination of pregnancy? Or I guess this is something that you will cover, Simon.
I would put it that way. I can say this is normal, and this is not normal. It needs follow-up. It needs further evaluation. So if I'm looking at a posterior fossa, I will never look at posterior fossa by if the CRL is less than 65, because it doesn't. Even cerebellar hemispheres are not seeing that very well. So if at all I am evaluating a posterior fossa in the first trimester, it has to be around 70 to 80 millimeter of CRL. I'll be able to see the cerebellar hemisphere very clearly. I'll be able to see the choroid plexus very clearly, and even in the vermis. These are the things which are seen. Most important is position of the choroid plexus in the fourth in the fourth ventricle, and that is that the comparison that is done only with your volume imaging, with the coronal section on one side and the sagittal section on another side. Grab a volume, evaluate simultaneously. That's the only way to evaluate the posterior in the first trimester. It's never 2D image, which will give you a clear clue about entire posterior fossa simultaneously.
Thank you so much, Prashant. And Simon is going to explain that in a lot more detail, because Simon's brief today is really to talk to us about evaluation of the posterior fossa in the first trimester, which I think it's fair to say is, for many of us, quite a novel idea. Most people think that the posterior fossa is really difficult to evaluate before the second trimester. So, Simon, look forward to your talk. I'm just going to introduce Simon briefly for those of you who are new to our webinar. Simon is a consultant sonologist at Mercy Hospital in Melbourne and the medical director of Monash Ultrasound for Women. He's got 50 members of staff in a tertiary level of ultrasound service there. So it's a big unit. And as you will see from his material, there's a lot of ultrasound being done there in great detail. He was awarded Sonologist of the Year in 2015, and he's got a real passion for teaching, but also is an avid researcher, mostly on early pregnancy screening, and he's described original sonographic fetal markers in the first and second trimester of pregnancy. He's currently the chair for the courses at ISWOG, and he's previously also served as a council member and board member for ASSAM and ASSAM Diploma of Ultrasound. So Simon, look forward to hearing your talk and how that then integrates with Gianluigi's talk on the second trimester. Thank you so much.
Gianluigi has shared, just a moment, Simon. Gianluigi has shared one message that most abnormalities of the posterior fossa seen in the first trimester are associated with chromosome abnormality or multiple anomalies. The value of the diagnosis is mostly the indication to look for other anomalies. That's what Gianluigi has shared.
Thank you. That's a very, very important message. So that not only it allows us to evaluate the posterior fossa itself, but also, of course, to as a marker for other anomalies. Gianluigi, please jump in if you have a comment. Just unmute yourself. But we'll listen to Simon's talk first. Thank you, Simon.
Iris, thank you very much for that kind introduction. And I can't tell you what a pleasure it is to be in such great company. The grandfather of fetal neurology is Gianluigi Pilu. And many of us who were brought up in obstetric imaging remember his textbook throughout the years and the various editions, and the enormous contribution that he has made to fetal imaging. So it is an honor and a great pleasure. And of course, Daniela, my good friend, who's come out and visited us here and joined us in the Fetal Neuro workshop, to have the world's authority on fetal MR and to have both of these with Prashant in the same room, it is a delight and a real honor for me. So I'm talking on the topic of the first trimester posterior fossa, and the talk is divided into these following sections. I'll give an overview of imaging in the first trimester, and I'll cover the normal landmarks that you are expected to see when you go to work on Monday morning on both sagittal and axial imaging. I'll then talk about an enlarged fourth ventricle and its association with aneuploidy, as Gianluigi just made reference to, and the enlarged fourth ventricle. More recently, we're identifying copy number variants and what the posterior fossa's role is in identifying these. I then will touch on posterior brain malformation, and I'll be discussing as much the limitations as the benefits of screening and diagnosis with regard to this area. I'll then touch on other brain malformation, and the new and exciting era is the 8 to 10 week scan, particularly with respect to the fourth ventricle, because we draw blood for free fetal DNA at 10 weeks of gestation, and we are identifying a cohort of fetuses at 10 weeks with a dilated fourth ventricle, and I'd like to share that with you. And then I'll finish up with some summary and some comments. But first, let's start with just normal anatomy at 11 to 14 weeks. So you're all familiar with doing an anatomy scan at the same time as measuring nuchal translucency, as you've been doing over the last 15 to 20 years. But what I want to try and do is to shift you away from just doing a BPD, but rather to do a 4-segment analysis of the fetal brain at 13 weeks. So if we start off in this clip, the first thing you see is your choroids, which occupy more than 50% of the lateral ventricles. This is your midline falx, and here is the fluid of the lateral ventricle as we sweep down from a superior to an inferior position in the fetus. The next is the fluid-filled space, which Prashant made reference to, which is the third ventricle. And then you come down to the rectangular box of fluid, the cerebral peduncles and the thalmi. And we measure the distance of the posterior border of the aqueduct of Sylvis to the inner border of the occiput as a screening test for open spina bifida. And then the last section after this is then going down to the fourth ventricle. And the fourth ventricle, which we'll be focusing more on today, is the fluid-filled space lined by the hyperechogenic tissue, which is the choroid of the fourth ventricle. And that's a very important landmark, because if you look at the echogenic tissue here of the choroid, you will see it stands out, and it allows you to define exactly where the fourth ventricle is. So if we freeze at this point here at the very end, this is the fluid of the fourth ventricle. And how do you know? You know because it's bound by the echogenic border of the choroid of the fourth ventricle. And these are very important landmarks in screening for structural malformation of the brain, but also screening for aneuploidy. So if I start off in the top right-hand corner and give you another variation of normal, which again Prashant touched on, which you see the fluid of the fourth ventricle, which is the black fluid-filled space. You see the hyperechogenic tissue of the choroid, and you see the outpouching of the Blake's pouch. Continuing down here, we see the cerebellum. And in this case, you recognize, in fact, this fluid-filled space is actually a little bit larger. For that, you may need to chart it. And then in the bottom left-hand corner, you will see that you've got a very significant increase in the fluid of the fourth ventricle. And how do you know it's the fourth ventricle? Again, you stick by that rule of thumb by seeing the hyperechogenic tissue, which covers all the way around the roof of the fourth ventricle, being the choroid. So that's what you would expect to image on Monday morning when looking at an axial section of the brain. This next is moving to the sagittal section of the brain, and you all recognize the fetal profile, the nasal bone, and the nuchal translucency, which is the screening test, which we do routinely for Down syndrome. But there is a lot more which you may gain by looking at these sections. The first is the anterior border of the brainstem, the posterior border of the brainstem, the roof of the fourth ventricle, which is the choroid, and then you have the occipital bone and the skin lines. And then you have the spaces, which is here, the brainstem. The next space after that is the fluid of the fourth ventricle. So this is looking at it in a sagittal section referred to as the intracranial translucency. And the last fluid-filled space is the cisterna magna. and then, of course, the fluid of the fourth ventricle. So you need to be familiar with these 6 lines and 4 spaces in a routine scan that you perform on Monday morning. Most importantly, where you'll be focusing on is in this talk is on the posterior fossa, in particular, the intracranial translucency or the cerebral fourth ventricle, because it is a marker of many things. So if you look at this case, I'll show you now in real time. This is a patient at 13 weeks of gestation. And now you recognize these landmarks. You recognize that this is the brainstem. You recognize that the fluid beneath it is the intracranial translucency or fourth ventricle. And this is the cisterna magna. The single most important observation you need to make and take-home message from this talk on the sagittal section is to recognize that in descending aorta that you have 3 black spaces, and this largest is the brainstem, next by the intracranial translucency, and then on to the cisterna magna. And if you just simply make that note of there are 3 spaces of decreasing size, you've leapt very significantly forward in screening for aneuploidy and fetal brain malformation. So in this case, while I gave examples of abnormals in the axial section, I'll do the same for sagittal. So first of all, when you screen in this sagittal section, you will recognize that the fourth ventricle is increased in this clip. So here is your fluid-filled space. So without placing any marker on it, you can subjectively see that your fourth ventricle or your IT is larger than your brainstem. This is your brainstem, and then beneath it is your fourth ventricle or your IT. In the bottom left-hand corner, you will see that the brainstem is enlarged and your IT is small. So if we look at this space here, this is your brainstem, and here is your intracranial translucency or your fourth ventricle. So simply, qualitatively, you could, by looking at a sagittal section, work out that you've got a problem. So what do you do next? In a sense, you want to know is, particularly if you're a junior in training, you say, that looks striking to me, either big or small. The next step is to move towards a charted to see what exactly the measurement is. And for each week of gestation, the measurement of the fourth ventricle increases in size. So when you think subjectively of normal, the next to do is to chart it. Is it large, greater than 95th, or small, less than the 5th centile? And the chart, which I like most of all, is just published only recently by Wilder, Sepulveda and others, because it's a very useful chart to put up on the wall in clinical practice. Because here's your fourth ventricle, here's your brainstem, the brainstem occipital diameter, and the cisterna magna. And these are the 4 markers that you will take in the brainstem and posterior fossa, and it gives you the 5th and 95th centiles. So take a picture of that screen, because that's very valuable when you subjectively suspect that there's a problem. What about axial imaging? Well, there's less data on nomograms for axial imaging, and this is by Eagle and others who, again, similarly, throughout gestation in the first trimester, the fourth ventricle increases. Interestingly, if you take the exact same point on the chart, is the measurement is slightly larger on axial when compared to sagittal imaging. So next is let's move towards aneuploidy and look at what role the posterior fossa plays in screening for aneuploidy. And this is, in a sense, a well-kept secret, this study from Kypros Nicolaides' group, because while we are focusing most of our attention, or have been over the last 15 to 20 years, on Down syndrome, the next most common chromosome abnormalities are 13, 18, and triploidy. And what is remarkable about these is that the fourth ventricle is dilated in the majority of these, particularly for trisomy 13 and for triploidy. And more recently, if you look at a study from Israel on triploidy, out of 21 cases in the first trimester of pregnancy, which they refer to as 12 to 16 weeks of gestation, the fourth ventricle is dilated. Now, that's a very important point, because we are screening now for Down syndrome no longer by first trimester combined screening in our unit. We are offering free fetal DNA, non-invasive prenatal testing. And in a sense, we will not pick up with NIPT triploidy. In a sense, it's one of the downsides of free fetal DNA. But if you look at looking at the posterior fossa with ultrasound, close to 100% of triploidies can be identified by looking at the posterior fossa and seeing that the fourth ventricle is dilated. So this is you on Monday morning. Your first patient, you go in and you start scanning. And as you scan this fetus, you see this is the head end here, and you think this is macrocephaly, or you wonder, is it actually hydrocephalus? But if you focus on the posterior brain, you see that the fourth ventricle is enlarged right here. And at that point, you raise suspicion. as you come down to a surface rendered image on the same fetus, you recognize when you look at the head end of this fetus, it's disproportionately large when compared to the trunk. So this is head end, and this is the narrow, slender trunk. And that's typical of the digynic form of triploidy. And then you move to focusing in on the brain, because you know that close to 100% of digynic triploidy will present with an increased fourth ventricle. And this is striking in this fetus. So an NIPT would be negative in testing with free fetal DNA, again, depending on which platform you use, but for the most common platforms. But ultrasound will bring you home in making a diagnosis. Similarly, in this case, when you scan through this, you'll see that there's subcutaneous edema, but you identify here that the fourth ventricle is grossly dilated. And in the same fetus, we also recognize that there was a structural heart abnormality. So this here is the ductal arch, and this is a reversal of flow here through the transverse aortic arch in a fetus with a hypoplastic left heart with trisomy 18. But the fourth ventricle, in a sense, brings you closer to that diagnosis. In this fetus, we started out thinking, in a sense, that we were looking at with a bilateral cleft lip, cleft palate. We were then suspicious that there was ventriculomegaly. But when we moved to looking at the fourth ventricle, it was clear that the fourth ventricle was grossly abnormal and grossly dilated. So seeing in the setting of facial clefting, in the setting of a dilated fourth ventricle, brought us to a chorion biopsy, which confirmed trisomy 13. And then there's this patient at 12 weeks and 5 days of gestation with a big cystic fluid collection arising from the posterior fetal neck, which is typical of a cystic hygroma. And the first thing you think of in this setting is Turner syndrome. And Turner syndrome has not really been described to be associated with an increased nuchal, but you never say never in medicine. And this is an example of a dilated fourth ventricle on both axial and sagittal imaging in a fetus with Turner syndrome, but it is far less frequent in seeing this finding. And this is a patient which we've seen more recently at 12 weeks of gestation. This is a transverse section through the fetal abdomen showing herniation of bowel into the base of the cord in a fetus that also had a cleft lip and hard palate. But what was remarkable about this fetus is that when we look in the bottom right-hand corner is that there was also dilatation of the fourth ventricle. So if we look here on a sagittal image, you will see that the fourth ventricle just here is raised. But for me, I think the axial section is more informative. And the main reason is because the area of the fourth ventricle is much larger on axial imaging when compared to taking a single mid-sagittal slice, and it is less striking. And in this case, it was a mosaic trisomy, and increasing with NIPT, we are seeing the rare autosomal trisomies and the mosaics. And we went on to conventional karyotyping after seeing evidence on FISH analysis. And there was 87% of trisomy and 13% of 18 and 13% of trisomy 2. And increasingly, we are going to see more of these in the era of free fetal DNA analysis. And on that same note, we are going to increasingly see more is copy number variance, particularly as we move into greater depth in analyzing free fetal DNA. And if you look at the fourth ventricle and that, when this fetus, when you look at the most striking thing is on sagittal is one, that you have a borderline nuchal translucency, but two, you've got a very striking increase in your fourth ventricle. And above it here is your second space, which is your brainstem. So clearly your fourth ventricle is much larger than your brainstem. And then as you go on to a 3D acquisition of the same fetus, as you actually acquire, you will realize that there is communication through the foramen of Monroe with the lateral ventricle in this fetus, which makes you suspicious that you've got a dilated third, communication through the foramen of Monroe with an increase in the fourth ventricle, that you would be suspicious that this would not just be an isolated dilated fourth ventricle as part of aneuploidy, but more as part of a Dandy-Walker malformation, seeing panventricular enlargement. But the other feature that stood out was that the long bones were much shorter than they should be. So femur should normally be at this sort of length at a 13-week scan, over a centimetre. So a very significant reduction in the long bones. And in testing on this chromosomal microarray came back with both a deletion and duplication in segments of 8p, known as the 8p syndrome, and an 8P syndrome, which is a rare abnormality, 1 in 30,000 births, but a strong association with autism. And most of these children require full care lifelong with complications of both cardiac, skeletal, and facial dysmorphism. Indeed, the facial dysmorphism in this fetus was pronathia. So it was pronathia with dilatation of the fourth ventricle, most likely part of a Dandy Walker, although it was never confirmed because the patient opted not to continue the pregnancy, knowing the natural history of 8P syndrome. And any time where you expect, this odd compilation of markers that doesn't fit with the common trisomies, remember that the dilated fourth ventricle is seen in this case in association with a radial ray deformity and brings you to suspect that you're looking at a copy number variant, not just the common aneuploidies. And in the bottom left-hand corner, you will see that this is a surface rendered image of the same fetus. And you will note is that there's this extension of both the arms, forearms, and a fixed flexion deformity, the tomahawk sign on both sides, with absence of the thumb and radius with a dilated fourth ventricle. And then, of course, there's always the unexpected. So this is a fetus who I saw only recently. When I started the scan, I could see in the top left-hand corner is that there was a duplex system. So if you look at the kidney just here, you will see that there are two ureters exiting out of this kidney, whereas the kidney on the opposite side, you will see has got a single ureteric exit point. So the renal pelvis are one on one side and duplex on the other. Now that's a common variant, particularly in females. So you take a 3D acquisition of this and it confirms your finding of duplex on this side and a unilateral on this side. What was odd though about this patient is that looking at the hands, that there was polydactyly in one hand and a normal count on the other. So the first shows you 6 fingers, a thumb, and the extra digit is on this side, adjacent to the fifth. And the other side was a normal digit count, so 4 fingers and a thumb. So to find unilateral polydactyly in the setting of a duplex system, I didn't really think I was looking at a chromosome abnormality until I came to looking at the fourth ventricle. As soon as I saw the fourth ventricle, if you go back to the chart that I showed you earlier, that of the trisomy 13, 100% of them will have a dilated fourth ventricle, and they typically present with bilateral polydactyly. So this was an exception to the rule. But what made me get, in a sense, to the home straight was identifying that the fourth ventricle was increased. So the power in that setting. Next is the Dandy-Walker continuum. So if we look at the Dandy-Walker continuum and we divide that into Blake's inferior vermian hypoplasia and Dandy-Walker malformation itself, let me walk you through these cases because they pose more questions than they give answers to questions. So the first is when you look at this posterior fossa, you now recognize that fourth ventricle is very abnormal. But in that same image, I don't know why my slides are skipping, but in the same image, you recognize that the aqueduct of Sylvius is dilated. And Prashant alluded to this. Just make note of it because I will come back to this later. But the first thing that strikes you is that the fourth ventricle is enlarged. The rest of the fetus was normal. We brought the patient back at 15 weeks and did an amniocentesis, and then it was banded karyotype. At that time, she was noted to have pulmonary valve stenosis. The posterior fossa was felt to be consistent with a Blake's pouch, and at this stage, we could see the features at the mid-trimester scan of the fourth ventricle outpouching into cystic fluid-filled space. Fenestration occurred, and by 30 weeks of gestation, we had a completely normal-looking vermis with normal vermian foliation and a normal fastigial point. And the anti-clockwise rotation had returned almost to a normal position. So that was a patient who presented all starting at a 12-week scan that led to the diagnosis ultimately of a Blake's pouch cyst. A little bit more sinister is in this fetus at 12 weeks of gestation, when we look at a thin nuchal translucency, we note, however, looking at the posterior cranial fossa, is that the fourth ventricle just here is dilated. More easily appreciated, though, is on axial imaging. We see this big dilated fourth ventricle, and we know it's the fourth because that's the choroid. And then this is taking a 3D volume, applying volume contrast imaging with volume speckle reduction imaging, which defines the brainstem. And you can see how much smaller that is compared to the fourth ventricle, which is grossly dilated. And tracking this patient through the pregnancy, it went on with a very different course, showing dilatation of the posterior cranial fossa, vermis not visible on axial imaging. But with the 3D reconstruction, we can see that tiny little fishtail appearance to the vermis with a very significant degree of anti-clockwise rotation. And the next case, very similar, but even more severe, is the Dandy-Walker malformation. So the posterior fossa dilatation, even more striking. And when we bring the same patient back at 18 weeks of gestation, we can see, firstly, there's a large posterior cranial fossa fluid-full space, absence of the vermis, wide splaying of the cerebellar hemispheres, dilatation of the third ventricle, and also dilatation of the lateral ventricles. And you can see elevation of the tentorium and sagittal imaging. So all the typical features of a Dandy-Walker malformation. But if you go back and you ask me the question, you've shown me three of in the spectrum of the Dandy-Walker continuum that you noted at 12 weeks of gestation. I'd say, no, I didn't note at 12 weeks. All I noted at 12 weeks was that the fourth ventricle was increased. I had no idea as to whether it was going to evolve into a Blake's patch, an inferior vermian hyperplasia, or a Dandy-Walker. In which case you would argue, well, if you can't arrive at a diagnosis in the first trimester, then you might be wise not to say anything. There is some light at the end of the tunnel, in a sense that I pointed out to you that the aqueduct is enlarged in the setting of a Blake's patch cyst, or is not visible in the setting of a Dandy-Walker malformation. But as Prashant alluded to, there were only 4 fetuses in that study that was just published very recently, 24 months ago. So there's much work to be done. But I do share with you, in a sense, our experience is no different than what was published by both Rabi and Dario. In this fetus, which was the first case of the Blake's pouch, you will see that the aqueduct is quite striking, as opposed to this case in the bottom left-hand corner, where you will see that the aqueduct of Sylvius is absent when I play the clip. And similarly, in the top left-hand corner, which had a dilated fourth ventricle, the aqueduct of Sylvius was absent. So it may well be in time that if we see a dilated fourth ventricle, confirmed that the chromosomes are normal, there's no copy number variance, there's no aneuploidy, that if we look at the aqueduct and see whether it's absent or present and large, it may help us to distinguish between these. But I say that very tentatively because we are only basing this on very small numbers and there's much work still to be done. There's then Joubert syndrome, which is a nasty condition presenting with mental retardation, ataxia, abnormal eye movement, and a litany of other physical manifestations of this gene mutation. 30 different gene mutations have been implicated in this condition. It's a primary ciliary anomaly. And the first case was reported by Quarello back in 2016, where he reported that the fourth ventricle is dilated. And in the setting of the fourth ventricle dilated, he also drew what was the typical molar tooth appearance that you see on MRI. The only comment to make about this case, however, is that they went into scanning it, knowing that she had a previous child with Joubert, and knowing that it was autosomal recessive, and seeing that the fourth ventricle was dilated, led them down the pathway of getting certain confirmation of Joubert. Based on the genetics rather than on the ultrasound criteria. And that's an important point to make. But I share with you, in a sense, similarly, a case, a patient at 12 weeks and 2 days with a grossly dilated fourth ventricle. And when you come down to looking at the midbrain, which has the molar tooth configuration, you see the very typical appearance. And you can see the roots of the canal almost of the molar tooth and that open space to the aqueduct of Sylvius. So exactly as you would expect to see an MR, and even more striking so in this case, when you look at the posterior fossa here, you will see, as you play this image here, that here you have your midbrain here and the roots of the molar tooth, which is essentially hypoplasia of the superior cerebellar peduncles, giving rise to this midbrain finding. And so in a sense, I think, yes, we can have clues to it, but for most of these, I would only really go down that track if I had a prior history. And here's another example of a fourth section analysis of a fetus in the first trimester with a grossly dilated fourth ventricle and that typical molar tooth configuration. What's also of note in this fetus is severe micronathia, and severe micronathia is also part of the Joubert syndrome. So phenotypically, yes, it had the features of it. But in a sense, driving down the pathway, I would need a prior history, I think, at this point, because the brain anatomy is still relatively primitive at this early stage in pregnancy. And I would be relying on the expertise of Gianluigi and of Daniela at the mid-trimester with both ultrasound and MR before making these diagnoses in the first trimester. And then there's the other brain malformations, and you're all familiar with the various forms of acrania. We've covered that on a previous webinar. But if you do see acrania with a dilatation of the fourth ventricle, just remember the association with trisomy 13. And secondly, remember acrania is also associated with trisomy 18. So it may be worth considering post-abortal karyotype, because many of us don't do that. If a fetus is acrania, the patient chooses termination. We don't arrange chromosomes as a general rule. But in the setting of seeing a dilated fourth ventricle, you might change your mind, because finding out trisomy 13 or 18 is helpful in counseling the patients. And then there's the moving to the complete opposite end of the spectrum. We've spoken for the last 15 minutes about the enlarged fourth ventricle. This is the absent fourth ventricle. And it was Rabbi Chowie back 11 years ago, time flies, who reported the absence of the fourth ventricle. And it sort of made sense, because you all recognize this sign of a banana-shaped cerebellum, obliteration of the cisterna magna, and the lemon-shaped head, which is the mid-trimester markers of spina bifida. What Rabbi's focused his attention on was on the posterior fossa, but doing so at 11 to 12 weeks of gestation, and recognized that the brainstem was increased and that the intracranial translucency or fourth ventricle was obliterated. And that began us on the journey in screening for spina bifida. And a wealth has been published looking at the charts as to the first trimester intracranial translucency. However, a lot of water has passed under the bridge, and we now recognize that, in fact, the fourth ventricle is visible in most fetuses with spina bifida in the first trimester, but rather the brainstem to the occipital bone is shifted, or the intracranial translucency may be reduced in size, which makes it much more challenging because we're measuring such a tiny space. So that's why I say in screening for spina bifida, I would encourage looking at the three spaces of relative sizes subjectively, rather than just focusing on the intracranial translucency, because its absence is present in the minority and not the majority. And we've learned that in the last 11 years since Rabbi first published it. And this is just showing you three examples of exactly that from 18, 19, and 20 of spina bifida showing dilatation of the fourth or enlargement of the brainstem with a tiny fourth ventricle. So the reverse of what we've been talking about. And here again, an enlarged fourth ventricle with a very narrow or shrunken intracranial translucency. But the other markers, in a sense, for looking at spina bifida, it was 2 years later that we reported on the midbrain. And in fact, if you look at it, the midbrain in the second trimester has no real value at all. But in the first trimester, it has real value. And I would encourage axial measurement of the brain, because what happens is that the brain gets shifted posteriorly. So I would encourage not only just looking at the three black spaces and measuring at least one at the first trimester, I'd also encourage looking in the axial section with regard to spina bifida detection. So in this case, you see what happens because the midbrain gets shifted posteriorly. And this is the sign that our first author here, Martha Finn, reported back in 2011, which is 2 years after the intracranial translucency was reported. And of course, for all these indirect markers, do remember that you then have to go to direct visualization of the spine to make the diagnosis, because you're not making a diagnosis on these axial or indirect markers. And from there, you look at the lumbar sacral region and you see all the features that are typical. And now I next encourage you, and I don't have the time to go over it, it's a little bit outside the scope of this talk, but published just a few weeks ago was a summary, a meta-analysis of all the published data looking at both sagittal and axial measurements and the sensitivity both of qualitative and quantitative. And clearly the axial view is here to stay. And I think we need to recognize that we need now two planes in imaging the posterior brain and the midbrain in spina bifida screening and diagnosis. I'll come to the very last segment of the talk, and this, as I made reference to the beginning, is the new era. And we are routinely doing blood at 10 weeks of gestation, drawing blood for free fetal DNA analysis. And this has taken over first trimester combined screening in the private sector in Melbourne. This gives us opportunity to look at the early fetal anatomy. And this is a fetus that has got a single anterior monoventricle here, which is a typical feature of holoprosencephaly. a condition where there's failure of cleavage of the cerebral hemispheres with a very dilated fourth ventricle, gross dilatation, in an embryo that measures 26 millimeters, 9 weeks and 1 day of gestation. And this is using a digital inversion cast, showing you here the single anterior monoventricle and here the dilated fourth ventricle. Increasingly, we are recognizing this group of patients in the first trimester who have a single anterior monoventricle and dilatation of the fourth ventricle. The only problem I would add to this, though, is we don't have a nomogram because the rhombic cephalon to start with and the aqueduct are quite prominent at 9 weeks of gestation, but that will come in time. But we recognize that this subjective enlargement of the fourth ventricle at a pre-NIPT scan is worth paying attention to. And this is a fetus who had a dilated fourth ventricle, and this heart, which measures 5 millimeters by 4 millimeters in size, demonstrates tricuspid valve regurgitation with a dilated fourth ventricle. I was expecting trisomy 13, but rather chromosome chorion biopsy a week later confirmed that this fetus had trisomy 21. And this is the same patient a week later, showing absence of the nasal bone and here a pleural effusion. So in a sense, it was a little bit of a surprise. So I'll finish up with the last two slides, is absence of the choroid. And this relates to the morphology of the roof of the fourth ventricle. And it was my good friend Waldo Sepulveda from Chile, from Santiago, who reported on this. And what his observation was is he compared normal, which is here is the echogenic choroid, the roof of the fourth ventricle, and this is the fourth here. He recognized that it was absent in a significant proportion of fetuses. So not only should you look at the fourth ventricle, you need to see whether the choroid is absent, because there's a strong association between the absence of the choroid and other central nervous system malformation. So in a sense, when looking at that, the fourth section, you may even wish to divide it into 5 sections. So in summary, the posterior fossa at 11 to 14 weeks is informative. It's informative for aneuploidy and microdeletions and duplications. It is informative with regard to some posterior brain malformations, but I would say tread cautiously in making any diagnosis at this point in time, because there is really no data to support early diagnosis. The aqueduct is interesting, but you need to balance the harm and benefit in counselling and offering genetic testing to these patients going forward. Remember, with a craniopharynx dilated fourth, consider a post-abortal karyotype. And I would say in future, as we screen for spina bifida, I think it is now clear from that meta-analysis that we need to look at an axial as well as sagittal imaging. And I would encourage measuring the occipital bone to the posterior border of the aqueduct of Sylvius to the inner border of the occipital bone. One final word, be careful, because the fourth ventricle may be a transient finding, and that's something to bear in mind in your counselling. So what does this talk mean to you on Monday morning? I hope it encourages you that when you go to work, that you won't just simply take a crown rump length in a DPD, that you will recognise that there are 4 sections to the brain. And then when you come to the third section on the brain, or the fourth section on the brain, that you will recognize the fluid-filled space is much easier to see in its whole area on axial imaging. And secondly, that the choroid is a very important landmark to see. I also hope that when you go to work tomorrow morning, that you will look at these 3 spaces and look at the relevant sizes. And if you see that the relevant sizes are not there, then you would chart the measurement to ascertain whether it is below the 5th centile or above the 5th centile in reference to the fourth ventricle. I thank you for your attention.
Well, thank you so much, Simon, for a fantastic overview of what can be achieved already in the first trimester. Really brilliant. We've got some questions coming up. But in the meantime, Gianluigi, I wonder if I can ask you to share your screen in the meantime so that we can make sure that your slides are visible. And please feel free also to join the discussion. While Gianluigi gets the slides up, Simon, there was a question about, to clarify the difference. Obviously, you've shown very nicely how the aqueduct of Sylvius is a sonographic landmark for neural tube defects in the first trimester. And already published that in 2011, actually, which is, longer away than you think when you think of 2011. It seems like yesterday we saw that paper. But there's a question from Jayshree. Can you clarify the difference between the AOS and the crash sign in the early diagnosis of open spina bifida?
Well, they're actually the same. Well, in a sense, they are the same thing. The crash sign is a subjective assessment of the midbrain displacement. And when we recognized that back in 2011, we recognized that subjective displacement. But we quantified it by measuring the distance between the posterior border of the aqueduct of Sylvius to the inner border of the occiput. The only problem was, Iris, that we didn't think of a sexy name for our paper. If we had thought of a sexy name like the crash sign, then people might know the paper a little bit better. But Fred came along a matter of weeks or years later and described exactly the same thing without measurement and called it the crash sign. And in a sense, it's exactly the same, describing exactly the same marker.
Describing that posterior displacement. Yeah. Thank you so much. Thank you, Gianluigi, for sharing the slides. And please, if Rajneesh can tell us if they're visible on the platform. I have another question from Patricia, actually. Thank you, Patricia, for joining. We have a case in the first trimester of a sort of molar tooth appearance, looking at the brain done by the aqueduct, but we suspect it's that molar tooth appearance. But we assume that we have to have an enlarged fourth ventricle at the same time. Can you get that molar tooth appearance without the appearance of that enlarged fourth ventricle?
Well, the answer is we don't know to that question, because if you look at the experience to date, that is a single case report. And then you have the two cases which I've presented, which were actually put on for live scanning. So I don't have any follow-up for those two, but what I see is exactly the molar tooth, a very abnormal configuration of the cerebral peduncles as they come around to the aqueduct. But, I would say to you in the first trimester, I have a great reservation. The reason being, it's an autosomal recessive condition with 30 gene mutations, and that will only account for 60% of Joubert. And if you start getting into a discussion with a patient at 12 to 13 weeks about Joubert, for which you may do a test and come back negative and you still can't exclude the condition, I would have reservations about raising that issue, and wait till you reach a point where you can make a call about inferior vermian hypoplasia, and that's 20 weeks of gestation, or maybe a little bit earlier, and not to get into that discussion before then, irrespective of what the fourth ventricle looks like.
Thank you, Simon. And I think also important what you highlighted, that the difference in screening a high-risk population from a low-risk population is very, very important in this respect. So unless you have a previous history of Joubert, I think applying a screening test to for a condition that is so very rare is just likely to throw many false positive cases. So be aware of it, but be cautious in the interpretation. Thank you so much. There is also a question about counseling, but I'm not going to talk about that, because I know that Gianluigi is going to cover some of that in his talk. And it gives me, just enormous pleasure to welcome Gianluigi here today. As Simon said, he is one of the absolute great authors, having published papers and books on fetal brain, normal fetal brain imaging. Gianluigi is a professor of obstetrics and gynecology in Bologna, where he also studied. As you all know him very well, I'm not going to spend much time to introduce him, other than to say that he has been the president of ISWOG in the past, and he is one of the few people who, or possibly the only person, who both got the Ian Donald Gold Medal for contributions in the field of ultrasound, and in addition the Stuart Campbell Award for educational contributions. So Gianluigi, thank you so much for joining us today on your Sunday morning from beautiful Bologna, and we really look forward to hearing what you have to say on second trimester imaging. Thank you.
Well, Alice, thank you very much. Thank you very much for the invitation. It's a real pleasure to be with you, and I was astounded by the wealth of information that the two previous speakers have demonstrated, and it has been very exciting. I'm very grateful to you all for being here. Well, this is the subject that you asked me to cover, which is the posterior fossa anomalies, and we will only refer to the cystic and the cyst-like anomalies. We will not discuss about spina bifida or other things. First of all, let me review a little bit the technique. In the second trimester of gestation, this is the image that is recommended to obtain by most national and international guidelines for the evaluation of the posterior fossa. It is a view that demonstrates the cerebellum and the cisterna magna. And for the purpose of screening, as we were saying before, it is important to distinguish between low risk and high risk. For the purpose of the low risk patient, this is more than sufficient. We are also supposed to take a measurement of the cerebellum, and I was very, very happy that very recently the Intergrowth collaboration has published a nomogram on the normal size of the cerebellum diameter. I'm very happy of that because the nomograms that we had before were not very good and they were conflicting. So I certainly would refer anyone to this new chart that has been published on the web of printing. We should measure the cerebellar diameter, and we should also look that there is some fluid posterior to the cerebellum. Let's say that the cisterna magna size is anything between 2 and 10 millimeters. And for the purpose of screening low-risk patient, I would say that is more than sufficient. Now, if, however, you are scanning a high-risk patient, then you need to do something more. You need to add 2 more images to that. An image that is commonly obtained by scanning a little bit lower than the level at which you obtain the transverse cerebellar diameter, that is useful to demonstrate the fourth ventricle, and most of all, to demonstrate that the vermis is present. That is the best way to assess the presence of the vermis. You can do it in a suboccipital-pragmatic view like this or in a coronal scan, but anyhow, it is important that you demonstrate that there is some echogenic tissue in between the cavity of the fourth ventricle and the posterior cisterna magna. And then it will be necessary to obtain a mid-sagittal or median view, which is the one that allows you to assess the integrity of the vermis. With the suboccipital pragmatic view or the coronal view, you assess that the vermis is present, and with the sagittal view, you assess the integrity of the vermis. You do that by a subjective analysis, as it has been pointed out before. The cerebellar vermis has a quite typical shape, and in the second trimester, it is fully developed. You see a small indentation anteriorly, which is the fourth ventricle, a triangular fluid filler structure, and there is a posterior indentation in the upper third of the vermis, which is the primary fissure. From the point of view of the qualitative evaluation, those are the only 2 landmarks that you are usually able to see in the second trimester of gestation. But it is important also to measure the cerebellar vermis if you are facing the possibility that there is some abnormality. And there are several nomograms that are available. And I would recommend to you, because I think is the most solid data that are available, this nice study by Vignals and his collaborator that was published many years ago, but it's quite valid, and it is in the public domain because it is on ultrasound in obstetrics and gynecology. I would certainly recommend you to obtain this table because it is quite important, and I think it's the best one that is available now. You can measure the 2 main diameters of the cerebellar vermis in the mid-sagittal view. You can also obtain the surface. It's hard to tell what is best. Usually we go with the diameters because the surface has a lot of variability. It has been pointed out before, of course, 3D is very useful. It's particularly useful to assess the vermis because You can assess the vermis by direct two-dimensional scanning, of course, but sometimes it is difficult to obtain the exact plane, and very frequently you don't know if you are in the exact plane. The value of 3D ultrasound is mostly that you can cut the volume that you have obtained in a very precise plane, and you can be sure that you are really looking at the vermis and you are not slightly off and you are looking at the hemispheres. So this is very, very useful. Which are the most common abnormalities that you are going to encounter when you are scanning the fetal brain? This is a study that we have published a few years ago. It was a study of cases that we collected in Bologna and in another large referral center, which is in Bari, Paolo Volpe and his collaborators, and we collected a total of 110 cases of posterior fossa anomalies. And as you can see, it would seem that by far there are three entities that are the most common ones. The so-called Blake's pouch cyst, by far the most frequent, the megacisterna magna, and the Dandy Walker malformation. Then there is an heterogeneous group of different type of condition, but they are a minority. And the most remarkable, the most important one in this group is the Vernian hypoplasia. Now, let's go over this group of conditions. The diagnosis of the megacisterna magna is a very simple one. It is a very large cisterna magna with a normal vermis. The recommendation, the threshold is 10 millimeters. So if you have a cisterna magna which is larger than 10 millimeters in the second trimester of gestation, which is over 3 standard deviation from the mean, then this is suspicious of a possible problem. It is important to assess that the vermis is normal, like with any of the other conditions we consider, and you will do that by obtaining a mid-sagittal view. And as you can see, that is a postnatal magnetic resonance imaging that was obtained in the same infant that confirms the finding. The main problem that we had with megacisterna magna is that sometimes it is difficult to differentiate it from other expensive lesions, such as arachnoid cyst or other type of cyst of the posterior fossa. Of course, if there is an asymmetry in the dilatation, this is most likely to represent a cyst which may be growing and may require neurosurgery at the time of birth, which is almost never necessary if you have a megacisterna magna. This is, however, by far the most common abnormality that you will encounter in the second trimester of gestation when you're scanning the posterior fossa of a fetus. The common term in the obstetric literature is a Blake's pouch cyst. This is in the obstetric literature, of course, because in the neurology literature, the Blake's pouch cyst is a much different type of thing. Is a type of hydrocephalus. So using the term Blake's pouch cyst may be inappropriate. And neuroradiologists now would favor another term which is less committed, upward cerebellar rotation. Because as we will discuss later on, as this is in the majority of cases a normal finding, a normal variant, maybe using the term Blake's pouch cyst is not appropriate, because it tends to stress on an abnormality, while in the majority of cases, this is not an abnormality. However, coming to anatomy, the most remarkable finding is the fact that you get the impression in axial view that the fourth ventricle is posteriorly open, like if there was a communication between the fourth ventricle and the cavity of the cisterna magna. In reality, there is not a communication because, as has been pointed out before, what we find in this case is an enlargement of the Blake's pouch, which is a cavity container within the cisterna magna. But the impression of ultrasound is that the fourth ventricle is open posteriorly through an opening, through a splitting of the cerebellum. Typically, the cerebellar vermis is normal, the transverse cerebellar diameter is normal, and the cisterna magna is not dilated. Once you have this image, it is important that you establish whether the vermis is present or not, and this is something that you do by scanning at a slightly upper level than the one that you see here, until you see that there is, like in the mid-image in this panel, echogenic tissue that is separating the fourth ventricle from the cisterna magna. Now, we were discussing before about caution. We made some terrible mistakes with this anomaly, because in the 80s, you have to understand that we used it to make diagnosis of cerebral malformation mostly with axial planes. And the axial plane of the open fourth ventricle was actually the same that had been described in CAT scans of Dandy-Walker malformation. So we made a diagnosis of Dandy-Walker malformation in some of these fetuses, and some of these patients requested a termination of pregnancy. And after that, pathologists demonstrated that the cerebellar vermis was normal. So that is how we discovered this entity. In the beginning, we thought they were just variation of the Dandy-Walker malformation that has a significant impact on intellectual development. We realized after that we were wrong, and this was a new thing that we didn't know it existed, and we made some mistake. Once again, this is important to remind. It is important to remind that we should not be over enthusiastic about our diagnostic ability, because there is always something that you didn't know it existed. The most important image, however, in these cases is once you have demonstrated that the vermis is normal, you have to demonstrate that the vermis is normal in a sagittal view. And you use the subjective approach that we described before, and you also use measurements that would allow you to identify at least the most significant types of hypoplastic vermis. A few other images. This is one of the cases in which we performed an unnecessary termination of pregnancy, and you can see that at 20 weeks the cerebellar vermis is fully formed, and you can recognize all the different aspects of these, all the different nodules that forms the cerebellum. This is a more recent image of magnetic resonance that confirms the same finding that we have seen before on ultrasound, and this is a postnatal magnetic resonance image. Once again, the dominant feature of this condition is that the cerebellar vermis is present and is normally formed, but is slightly displaced upward because of an expansion of Blake's pouch. As you can see, rotation is always limited, and we will return to rotation later on. Typically, Blake's pouch cyst or upward cerebellar rotation, as an isolated finding, is associated with a slight degree of rotation of the cerebellar vermis. This is Dandy-Walker malformation, which is more rare than we thought at the beginning, and these are the typical findings. As you can see, the open fourth ventricle sign is there, but typically the cisterna magna appears larger. It is always increased in size. But the most important image to make the diagnosis is the median plane, in which you can demonstrate that there is a vermis that is typically small, very frequently is dysmorphic. You cannot recognize the normal anatomic landmarks that we have described before. And also, as you can see, there is a marked rotation. The findings are usually less prominent in the second trimester of gestation. Mostly the cisterna magna is not that big, as you can see later on, but the wide opening of the fourth ventricle and the small size and significant rotation, marked rotation, in the range of a square angle almost of the cerebellar vermis are quite evident even at this time. Now, we described this several years ago, and this is an observation that caused much discussion, and there is a lot of people that believe that it is not useful at all. We believe that it is useful. We have seen that with Blake's porch cyst, with the typical finding of an isolated Blake's porch cyst, at least their rotation is always slight. As you can see, in normal fetuses, you can have some slight rotation. Sometimes you can get the impression that there is some posterior opening of the fourth ventricle, even in a completely normal fetus. And we have seen that fetuses that had a rotation of up to 18 degrees between the brainstem and the anterior portion of the cerebellar vermis are always invariably normal. Blake's porch cyst is something that on average is in the range of 25 to 35 degrees. And I hope that you can see the Dandy-Walker malformation, because with Dandy-Walker malformation, the angle is always very significant. It is very close to 90 degrees. As you can see, there is much difference between the degree of rotation. Now, of course, I don't think that you make this diagnosis using rotation only, but if you have a rotation that is less than 20 degrees, I think you should not worry at all. And if you have a rotation that is in excess of 40 degrees, well, most likely that is not an average isolated Blake's porch cyst, and you should think to something else. A few other conditions that deserve to be mentioned here, and Simon has already described the Joubert syndrome. Joubert syndrome is difficult. It's a difficult diagnosis to make in the second trimester of gestation. I was quite amazed at seeing the molar tooth sign so well demonstrated in the second trimester, because as you will see, we can see it in the second trimester, but not that well. I think that these images that have been obtained in a neonate with magnetic resonance explain very well what is the nature of this condition. Usually, the vermis is completely absent or almost completely absent, and the two cerebellar hemispheres tend to touch in the midline. Now, this is an important point to remember, because the point is that in this case there is no vermis, but it's difficult to figure it out in the median plane because you can see tissue because of the two cerebellar vermis that come into contact. Only that the mass of tissue that you see is much more irregular. It does not have the anatomic landmarks that we have described before for the cerebellar vermis. Postnatally, the hypoplasia of the cerebellar peduncles result in that very, very typical appearance that Simon has well described before, which is called the molar tooth, which is not specific only to the Joubert syndrome, but also to other conditions of vermian hypoplasia. But it is a very typical finding. Prenatally, in the second trimester of gestation, the most important finding to suspect Joubert syndrome is that you have an open fourth ventricle with the two cerebellar hemispheres that are not widely separated. They are quite in close contact, but you can scan up and down, and you are never able to see the cerebellar vermis in between. French people who are a little bit naughty used to call this the buttock sign, which I think gives you the impression of what is the finding. Then you make a definitive diagnosis by scanning in the median plane and seeing that there are no of the normal anatomic landmarks of the vermis. There is not a well-defined fourth ventricle with a triangular appearance that we have seen before. There is not the prominent the indentation of the primary fissure, and the mass of tissue that you see is usually much larger than the vermis because it is made by the two hemispheres that touch in the middle. You can get a similar image to the molar tooth also with ultrasound, and so it is less remarkable, I would say, than what you see on magnetic resonance, because ultrasound is a different tool. But typically what you notice is that there is some separation between in between the two cerebellar peduncles. Verminal hypoplasia, well, that is one of the most difficult things to recognize. Typical finding is, of course, the opening of the fourth ventricle. When you see the opening, are faced with three entities. Number one, the most frequent condition is the Blake-Sporch cyst. Number two is the Dandy-Walker malformation. And number three is verminal hypoplasia. Sometimes, even subjectively, you can make the diagnosis immediately. If you compare this typical image of the Blake-Sporch cyst, in which you see that there is mild rotation of the cerebellar vermis, but the cerebellar vermis that has a normal appearance, that has a normal size, and then you compare the image in the middle, and you can clearly see that the vermis in this case does not have a normal shape, and it has a size which is almost a half of what it should be. Then the diagnosis is quite easy. The other case is interesting because this is a case in which there was much discussion between different sonologists. We were not agreeing whether it was hypoplasia or not. Some of us believed that it was normal. Some of us believed that it was hypoplasia. And then the karyotype came in, and believe it or not, at 20 weeks, this was trisomy 13. And this was really the only clear abnormal finding in this case. A few data, because I think they are remarkable. As you can see, as we discussed it before, Blake-Sporch cyst, megacisterna magna, and then the Walker malformation form the bulk of the case that you will see. And one important thing is that both the Blake-Sporch cyst and the megacisterna magna may regress in utero. They may disappear. And that, makes you believe that probably, at least for the Blake-Sporch cyst, this is just delayed normal development. We should probably consider this not as a malformation, but rather as a risk factor for a malformation. We have expanded our experience, and we came with the same conclusion. Roughly 40% of the cases of Blake-Sporch cyst that we see in the second trimester of gestation disappear, and the infant are completely normal at birth. And at a lesser extent, but even the megacisterna magna may disappear. I have 2 minutes, so I will finish in time. As you can see, disappearance of the finding with Dandy-Walker malformation of verminal hypoplasia, we have never documented. It is important to remark that we are not always accurate, despite the fact that all these examinations were performed by expert sonologists. As you can see, in a few cases, a different diagnosis was found after birth. If you compare ultrasound with magnetic resonance, you have to accept what is the rule of the game. Magnetic resonance tends to be slightly more accurate than ultrasound. So I think whenever you have a posterior fossa anomaly in the second trimester of gestation, magnetic resonance is indicated, with the possible exception of the Blake-Sporch cyst, at least in our own experience. As it has been pointed out before, these anomalies are frequently associated with other anomalies, and particularly with chromosomal aberration. By far the most frequent association with the Dandy-Walker malformation, but even as you can see with verminal hypoplasia, it is possible. And we also had a few cases of abnormal chromosomes with the Blake-Sporch cyst. So in reality, it really would seem that chromosomal analysis is important in these cases, as the search for copy number variants. Simon has already discussed it. There is a lot of experience in these cases. Whenever you have some type of posterior fossa anomalies, the probability that there are pathological copy number variants is quite high. whether this is associated with other malformation or even if it is an isolated condition. Iris has already discussed the systematic review of posterior fossa malformation that has been published a few years ago. And as you can see, the abnormal outcome is an important proportion only in cases with Dandy-Walker malformation. If you consider the cases that are diagnosed with Blake's pouch cyst, they usually are quite normal at birth. In the overall majority of cases, they have a completely normal outcome, as well as the megacisterna magna. And one may debate whether this is increased over the general population or not. What is important to remember is also that vermian hypoplasia is frequently not confirmed after birth. Most of the cases, a large proportion of cases that are diagnosed with vermian hypoplasia in the second trimester are found to be normal at birth, and it would seem that the proportion of neurologic sequelae in these cases is quite limited, which makes counseling is particularly difficult in these cases. Last condition that I would like to remember is the cerebellar hypoplasia. Cerebellar hypoplasia, in our experience, has a very, very poor outcome. If the cerebellum is small, most likely the outcome will be very poor. Unfortunately, this is a diagnosis that can be made in the second trimester, but in the vast majority of cases, we have seen this to develop through gauge gestation. This is a typical case. As you can see, that was the screening examination at 20 weeks, and the cerebellum is completely normal. But when the patient was scanning again at 33 weeks, as you can see, the cerebellum was very small, and this infant had a very severe neurological abnormalities and died soon after birth, as is frequently the case with this type of condition. To conclude, despite the fact that we have excellent tools in our hand, you have to expect that there will be some diagnostic accuracy in a minority of cases, and of course you have to take that into consideration. Magnetic resonance increases the accuracy, not very much in reality, but all studies come to the same conclusion. Magnetic resonance is slightly more accurate than ultrasound, so if you have the availability of these results, of course, you should use it. The two most common anomalies, megacisterna magna and Blake's pouch cyst, are not malformation, because in reality the vast majority of the infants are found to be completely normal at birth, but they are rather risk factors for malformation with a high probability of intrauterine or postnatal regression. Isolated vermian hypoplasia is frequently not confirmed after birth and usually has a good prognosis. The outcome of isolated and the Walker malformation in prenatal series is comparable to the pediatric data. That is about 30 to 40% of these infants will have severe neurologic sequelae. Thank you very much.
Thank you, Gianluigi. This is such a beautiful overview, starting from that normal anatomy all the way through to the outcome. So I hope that your lectures answered quite a lot of the questions that were coming in through quite early on. For example, the prognosis of Blake pouch cyst, and whether it's associated with intellectual dysfunction in the baby. Raf Napolitano has joined us today, and thanks, Raf, for joining us. If Blake pouch cyst, Raf is asking, is truly a normal variant, how is it that there is still a significant number of those fetuses in the systematic review that have associated abnormalities or chromosomal defects? Is it really, how can we be sure that this is just a normal developmental, normal variant, if you like, rather than a true abnormality?
We have expanded our experience, and right now we have slightly over 100 cases of lake spot cyst that was diagnosed in utero and was completely isolated. By completely isolated, I mean that there was a normal scan, no other associated malformation, and a normal karyotype and a normal CGH array. And none of these fetuses were abnormal. So to me, I think the bottom line is that this is a risk factor for other anomalies. But honestly, if you do not see any other anomalies, this should be considered a normal variant. That has been our experience.
Thank you, Gianluigi. Now, I'm just going to ask Daniela in the meantime. Daniela, if I can ask you to start sharing your slides, because we just want to make sure that your slides are working. And I'll continue the discussion meantime, because there are some other questions. When the vermis is elevated or when the vermis is rotated, how can we accurately measure it? How are we going to get a handle on the development of the vermis in that circumstance? Do you have any tricks of the trade that you can share with us, Simon or Gianluigi?
My preference would be with 3D volume and VCI and a sagittal imaging through the posterior fossa at a vaginal scan, because it defines the border of the brainstem, defines the point is, where do you place the two lines, where do they meet? And it's that definition of that point. So I would say vaginal scan, posterior fontanelle, high frequency transducer, 3D VCI. But I mean, that's in the perfect world. In the real world, the baby's lying by breech, and you're doing a transabdominal scan. But I think the best way to do it is to try in that scenario is to do 2D real-time imaging on a sagittal plane. I'm sure Gianluigi would maybe comment to that. And then how you actually where you actually place the calipers, I'll just be very interested what Gianluigi has to say to that, because it's a very good question.
No, I completely agree with you. And of course, if you do not have the ability, or if you have a difficult case, you can always use magnetic resonance. I mean, and maybe defensive medicine, we are doing magnetic resonance in all our cases. And the images are quite good. I would be happy to hear what Daniela has to say about that. But in general, I think that it is possible, certainly possible, to make a diagnosis. And it is of utmost importance, because as I told you before, the vast majority of these infants will be completely normal. One may wonder what is the significance of a slightly smaller vermis in these cases. What is the relevance of an hypoplastic vermis? Because in reality, when you look at the prenatal series, there are many. It would seem that if you have a rather small vermis, but nothing else, it has a very little impact.
Yeah, and also enormous variation, both in the normal range of the vermis, but also in the ability to measure it accurately. I think it's something that, I would exercise great caution. I have a couple of questions that sort of moving from first to second trimester. One from Jacqueline says, say you had a fourth ventricle that was dilated in the first trimester, and moving forward, it's become evident that this was a transient finding. Is this still abnormal? Do we need to do anything further? Or was this just something that happened during the development, and we can now ignore the fact that earlier on that fourth ventricle seemed dilated?
I think I'll pass two comments to that. Well, the first is there's only a single publication of two cases of a resolving dilated fourth ventricle in the first trimester of pregnancy that had a normal outcome. There's no, other than those two cases, to the best of my knowledge, may the others want to comment, I know of no other cases. The second comment is that I think it's underreported. I think that if you look at centile charts in anything in medicine, there's a 95th centile. So 5 out of 100, you're going to find the fourth ventricle that's elevated, and therefore we are not calling these. And that sort of tells me a story that people probably aren't looking at the fourth ventricle, because there are a certain proportion, when you do a vaginal scan, you say, wow, that fourth ventricle looks big. and then you chart it. And if you are actually doing it according to the book, 5 out of 100 should be finding with a dilated fourth ventricle. Now, a certain proportion of those will be the group that are aneuploid, copy number variants, and a certain proportion of them, which will be much smaller numbers, will be the Dandy-Walker continuum. But my guess is that most of them would actually be normal, but it's not been reported.
Thank you so much. Just very briefly, Daniela, if in the meantime I could get you to share your screen so we can see that your PowerPoint slides are coming up on the other stream. So just share your slides and then we'll continue the discussion meantime, if that's okay. Is that all right, Daniela? Or you're muted at the moment. Thank you. Fantastic. Thank you so much, Daniela. We'll wait a few minutes just to make sure that on the live stream they're also working. But please, Prashant, you had some comments to make also.
It was when you are encountering a dilated fourth ventricle, please look for the aqueduct. If it is too big or it is too small, too narrow, especially in the first trimester, make sure that the chances of abnormal posterior fossa is more likely. You have got a good adequate size of aqueduct along with a little bit of dilatation of the fourth ventricle. It could be a physiological normal variation, but too small or too big aqueduct associated with fourth ventricle dilatation, make sure that you evaluate them frequently after 3 to 4 weeks after first trimester. That would give you time to investigate it at appropriate time.
Can I make a comment?
Please, Gianluigi.
I would like to point out an observation that was made by Simon before, which I think to me is very relevant, because the practice is changing. We have been performing combined screening for many, many years, and now all over the world it is shifting to ultrasound and IPT. And this is a major change, because in IPT, we will not see a lot of things that we were seeing with the combined screening that are important, of course. So there is a much increase of the responsibility on those who are performing ultrasound, not only on the measurement on the nuclear translucency, but screening for uncommon chromosomal aberration and abnormal micropathological copy number variants will depend entirely on ultrasound. And there are not many things that you can see with ultrasound clearly in the 11, 13 weeks. Now, it would seem, we have the same experience as Simon, that a lot of abnormalities share in common something that is different than normal in the posterior fossa. So there is a very important area to look for, particularly if you are in the new practice of performing NIPT and ultrasound. I think that there is a wealth of information that you can get from there. And of course, one should be cautious. You should not counsel about termination of pregnancy if you have a large fourth ventricle. But among those who have a large fourth ventricle or have something other abnormal there will be a lot of fetuses with wear and very severe abnormalities that may escape detection, may eventually escape detection.
And I think this is exactly why this area is difficult, and we will look forward to Daniela's talk. But I will just take a couple more questions. We've got Tom Everett asking, and also Robert from Baylor. Gosh, Robert, you're up very early this morning, or tomorrow morning, or last night, or wherever it is. What proportion, Simon? You showed those beautiful images. What proportion of these first trimester scans are transabdominal, and what proportion are you doing transvaginally, roughly speaking?
Well, our practices may be slightly different to others in the sense that our transvaginal rate is over 95%. So we ask patients to sign a consent form when they attend the practice for a first trimester anatomy, and they understand that the purpose of the scan is an anatomical assessment. And in a sense, it's in the culture in the region of where I work that endovaginal scan has got better detection rates. And we know that. The published data supports that if you combine transabdominal with transvaginal, the detection rate of malformation in the first trimester is better. And therefore, the answer to the question is we do both. But the patients are booked for half an hour. The transabdominal scan is done for the nuchal translucency because that's much easier TA. We do as much as the anatomy as we can. Then we get the patient to empty the bladder, and then routinely they have an endovaginal scan. Now, that's very different to what happens at the Fetal Medicine Foundation in the UK or broadly across the UK and many other countries globally, where the scan is done transabdominally, and if you suspect a problem, then you go to endovaginal scan. But I suspect that will change. Exactly the point that Gianluigi just made is that the scan in the first trimester, if it's going to survive, it's going to survive on the grounds that it's a screening test for malformation, not a screening test for aneuploidy, because the way we are going with free fetal DNA, not just for aneuploidy and copy number variants, it won't be long before we're going into wider into the genome, in which case you're going to ask yourself the question, what is the purpose of a first trimester scan? And if we truly believe that the first trimester scan is a screening test for malformation, I think it is very likely that many will switch from the practice of abdominal imaging to routine endovaginal imaging. And it's a matter of time.
It's the same questions are coming in thick and fast now. So I may just very quickly get through some very quick questions. Karyotyping. So you've seen something suspicious of Dandy-Walker malformation. Please let's move away from this Dandy-Walker variant or Dandy-Walker continuum. I find it very confusing. Let's just use the right words for the right things. So there's Blake patch cyst, there's vermian hypoplasia, there's cerebellar hypoplasia, there's megacisterna magna, and there is Dandy-Walker malformation, which is a specific entity. And I think it would be much better to forget about this Dandy-Walker continuum or Dandy-Walker variant because it's just too broad. And I would much prefer us all to talk about exactly what the malformation is. So if you see in the posterior fossa 12 weeks a malformation that looks like Dandy-Walker malformation, is that enough to offer karyotyping? Is it okay just to do an NIPT, or should we be offering a CVS?
Well, there are two parts to that question. The first is that for most who we see a dilated fourth ventricle in the first trimester of pregnancy, it's aneuploidy that's the most common cause. With regard to Dandy-Walker malformation, exactly the point that Gianluigi made in the second trimester, that these are striking increased fourth ventricles. It's the same in the first trimester. When you see Dandy-Walker malformation, the first trimester, again, the numbers are very small, Iris, but it's a striking enlargement of the posterior fossa. I showed you the example of where it was gross dilatation, and she had panventricular dilatation at 18 to 20 weeks, and similarly for the Blake's pouch. But I think the more it goes down the spectrum, the severity in the first trimester, the same philosophy translates into the first trimester. The more severe the dilatation, the more likely I am to go down the pathway of offering genetic testing. But I'm so nervous about it because there's no data out there. And I just see it through the lens of screening for chromosome abnormality and copy number variants. And therefore, my next question is, does the rest of the baby have any other marker that tells me there's trisomy 13, trisomy 18, triploidy, or copy number variants? And if it does, genetic testing. If there isn't anything else, and I have a borderline increased fourth ventricle or mildly increased fourth ventricle, I will say nothing in that scenario. I will put it in the group that patient needs to be booked back on my list when she comes back for review. If the patient has got severe dilatation of the fourth ventricle, I have no likelihood ratio for that, but I do have a high index of suspicion that it is a posterior fossa anomaly. Then in that scenario, I might get into a discussion in the setting of a Dandy-Walker. But Iris, I don't have any data to back that. All I have is, in a sense, 27 years of practicing endovaginal imaging to put to that. But I'm more towards saying that you need to be cautious and not go down that track if you don't have data to support it. If it's new ground, you don't know what the outcomes are, you know how variable the posterior fossa behaves even after the second trimester, I would tend to say not go there.
Thank you so much, Simon. Gianluigi, there's a question about the echogenicity in Blake pouch cyst. Is it true that the Blake pouch cyst, the fluid in the Blake pouch cyst, is of a different echogenicity than the cisterna magna? Can we distinguish them?
Yes, that is certainly true, of course. That is very true. Because the Blake's pouch contains the same fluid it's like the ventricular system. It's an posterior expansion of the ventricular system. The cisterna magna is fine septation, and but that is not particularly helpful in terms of diagnosis. The bottom line is that what is really important is the cerebellum, the integrity of the cerebellum. Mm-hmm. If the cerebellum, if the vermis is rotated, the cisterna, there will be a Blake's post behind that. I mean, it does not levitate. There must be a cyst, and the cyst is the Blake's post. It's always there.
And related to that particular question, Apostolos is asking, do you then use the angle, the tentorium angle, in order to establish that still? Or have you moved away from that?
We have used different type of angles. We think that what is mostly useful is the angle between the brainstem and the vermis, just for this reason. If there is a lot of rotation, it is much more likely that there is a problem. And in our own experience, the vast majority of those that had a rotation angle greater than 40 degrees, they had a cerebral malformation, whether it was a Dandy Walker malformation or it was something else. So I think it's very useful to orient, not to make the diagnosis, but to orient versus one case or the other. If you have a rotation of more than 40 degrees, it's very unlikely that it is a simple Blake's pouch. It's more likely that there is something else.
Now, I'm going to ask you the last question, Gianluigi, and Daniela, we will move on to you. People are asking, how can we make sure that in our routine practice, we don't miss vermian hypoplasia? Should we add to our routine scan a mid-sagittal plane? Should we measure the cerebellar vermis routinely? Or are we okay just to follow the axial planes that you showed for routine examination in neurosonography? What is your clinical...
Well, my strong recommendation would be that in low-risk patients, you just go with the suboccipital back view, and that is enough. With a transverse cerebellar diameter, and that is enough. Because if there is opening of the fourth ventricle, you will see it. So I would not recommend in a low-risk patient to do anything else. That is my strong suggestion. Because if you enter into the issue of measuring the cerebellar vermis and diagnosing cerebellar vermian hypoplasia, which is in itself a very elusive entity with no clear demarcation, because you don't know what will you consider. 2 standard deviation below the mean, 3 standard deviation. As you pointed out before, the available data suggests that you have isolated vermian hypoplasia. I mean, the impact in terms of neurologic outcome is almost nil. So,
Gianluigi, this is a really important question. We need to screen with care. It's possible to measure everything in the baby. If you measure 20 things, you will find one that is less than the 5th percentile. If you measure 40 things, you will find 2 things that are less than the 5th percentile in a completely normal, healthy population. So I think it is important to have a balance between screening, but also understanding that screening will show up screen positives. And when we have ill-defined outcomes in that screen positive population, most of which have a normal outcome, perhaps, screening more generally with that look into the vermis, that difference between the fourth ventricle and the posterior fossa may be enough. I'm going to stop the discussion now. I'm sorry, I know there are many, many questions, but I'm going to move forward to Daniela, because I know that Daniela is going to answer a lot of our questions, because all of us in ultrasound, when we're really, really stuck and we don't know what more to do, one of the things we can do is ask for our MRI colleagues to help us, and there's no one better than Daniela. Daniela is a professor at the Medical University in Vienna and head of the Department of Neuroradiology and Musculoskeletal Radiology in the Department of Biomedical Imaging. Of course, we all know Daniela as a world expert and specialist in developmental neurology. She's a board member of, was until recently a board member of ISWOG, also the European Society of MR and the Austrian Society of Perinatology, the RSNA, the European, the Austrian Societies of Neuroradiology and Prenatal Diagnosis. The list is too long, Daniela, to go through all your achievements. So instead, we're going to concentrate on the science and look forward to your wonderful presentation on how MRI can contribute and help us in the assessment of these difficult patients.
Thank you, Iris, for your kind introduction. And of course, it's really a pleasure and an honor for me to talk in the same session as Prashant, Simon, and Gianluigi. The posterior fossa, what can MRI contribute? Well, let's ask the sonographers. There are some recent publications saying the main advantage of MRI is the assessment of vermis morphology and brainstem, especially in the third trimester. It has been found to be better than ultrasound in the evaluation of the torcular. I will show an image right afterwards. And in the identification of associated malformations and brainstem anatomy. And what we can see here is an example out of a paper by Laurent Guibault, who found that MRI is better than ultrasound in the identification of the position of the tentorium and the torcular, because this anatomic landmark can really help us in diagnosing a Dandy Walker malformation and differentiate it from other similar malformations in which the position of the torcular should be more normal. What about Wormian biometry? Of course, it is also feasible by ultrasound. What can we measure? We have already heard that the vermis length, height, the inferior Wormian distance, the brainstem tentorium angle, the brainstem Wormian angle, the anterior lobe, the posterior lobe, and the cerebellar volume. And sometimes MRI was thought to be superior and sometimes not so much. And here you have an example how we measure, and you will see the measurements are just the same as they are performed by ultrasound. But now, what is really the gold standard for all that? Is it ultrasound? Is it MRI? Well, the standard of reference is always the outcome. And so we really have to try to get an outcome of all these cases, either per postmortem workup or by observing the children, not only after birth, but also when they are older. There are a lot of pitfalls in Wormian biometry. The growth of the vermis may catch up later. We have seen that really nice embryologic pictures by Prashant already. And I show you just an example of a fetus in gestational week 19, where the vermis was regarded to be small, but it was growing. And at gestational week 24, it was completely normal. So this might be a problem, especially in countries where you have to decide upon termination of pregnancy at very early gestational ages already. And here the already mentioned brainstem Wormian angle. Here you have a fetus at gestational week 20. And here you have the same at gestational week 24, and the brainstem Wormian angle is much smaller. And on the right side, you have a similar example. So same as Gianluigi already said, if the brainstem Wormian angle is about 40 degrees, it rather becomes better than worse during pregnancy. What about Wormian lobulation pathologies? Because it is important what part of the vermis is involved into a malformation. And regarding Dandy Walker malformation, this has been known for a long time already since the first description of Dandy Walker malformation, because the part that is indicated by these yellow arrows, this part is, can you see it, is always involved in Dandy Walker malformation. It's the nodulus. And if you have a displacement of the nodulus, as you can see it here, then it is easier to make this diagnosis. Well, we tried to delineate the Wormian lower lip at first at postmortem MRI and compare them with pathology. That's what you see here. These are the known parts of the vermis, and here you can see what we found postmortem. We could distinguish the lingula from the centralis, the culmen, the decleve, the folium, and the tuber. And as these parts usually cannot be differentiated from each other, we call it the FDT complex. The pyramis, then you see the uvula. I have just to transport this image. Yes. And also the nodulus. And then we transferred our experience to living fetuses. And we saw that we also were able to do that segmentation in vivo. And we compared it with postmortem experience. And what was found is that 7 of 9 lobules were almost always visible at gestation week 20, and the measurement error was generally below 5% between the living fetuses and the postmortem samples. What we also know is that the respective lobuli do not grow at the same speed. This is from Adamsbaum publication already a lot of time ago. And what you can see here is that some parts grow faster than the others. So the primary fissure, which is also a landmark, moves upwards during pregnancy. And we did that also using MRI, and we found that some parts of the vermis decrease in growth, the lingula, the centrum, the pyramis, and the nodule. The uvula has a stable growth, and increasing is the DFT complex and the culmen. And then we transferred this knowledge to pathological cases, where not only the parts of the vermis were measured, but also the parts of the pons. I will come to that later. Here, just what was found is that in healthy normals and in Megacisterna magna, you can delineate up to 7, mostly 7 Wormian lobules. And in Blake's pouch, the number of lobules that you can delineate decreases, even more in a hypoplastic vermis, and in classic Dandy Walker malformation, the least number of lobules of the vermis can be delineated. So perhaps this helps, at least using MRI, to differentiate these almost normal conditions from really pathological conditions. Because as Gianluigi already said, MRI has been found to be a bit better than ultrasound, but not too much. And our way is now to really describe our findings better morphologically and with greater accuracy here. If you have Wormian agenesis or dysgenesis, you mostly think of malformations, but there are also other conditions leading to Wormian dysgenesis. What do you see here? There is too much fluid around the head of this fetus in gestation week 23. So there is Wormian hypoplasia, nuchal edema. There is also hepatomegaly and splenomegaly. And this is a metabolic condition. It's CDG syndrome. So what we have to do on MRI, we also even if you send us a patient where you say, oh, please only look at the vermis, I have seen everything else, we always look at the whole fetus in Vienna, because otherwise sometimes it's really very, very difficult to make a definite diagnosis. The vermis agenesis and dysgenesis is a salient feature in type 2 lissencephalase and alpha-dystroglycanopathies. As you see here, some examples of a small dystrophic vermis. Here it's a bit blown up so that you can see that better. And in these conditions, we have also malformations of the pons. What we know here, there is a fusion of the vermian lobuli, so we will not be able to delineate the lobuli as we normally can do that in just small vermian in vermices that are all just small, but here in these conditions they are also deranged. This is of course known for a long time, also from animal studies. If you have vermian agenesis and dysgenesis and brainstem malformation, this points towards certain pathologies, especially if you have an embryonic brainstem here. And so we find that also in tubulinopathies and, as already mentioned, in dystroglycanopathies. Here you see the pathological specimen clearly showing also the over-migration of the neurons into the subarachnoid space. Well, let's look at brainstem anatomy as it is seen on MRI. We have here some postmortem specimen showing the growth and the formation of the brainstem, as already was shown before on pathological specimen, but here on MRI. And here it is a bit blown up so that you can see the shape of the brainstem as it develops a bit better. But also here we were interested in proportions and measurements. So if we look just at the proportions, what you can see is that the respective parts of the brainstem also show different growth patterns. So the mesencephalum decreases, the pons increases, and the medulla oblongata also became smaller. So what we are going is from a relationship from 2 to 1 to 2 to quite the reverse, from 1 to 2 to 1. And this helps also in the decision whether a brainstem is formed pathologically or normal. Here, the measurements published by Gregor Dowiak this year in UOG. And here is an example of a preserved embryonic shape. You don't need measurements for here. You see not only the proportions are pathological, but clearly the shape, because this is an embryonic shape. Sometimes pontocerebellar hypoplasia is a part of a syndrome, and this fetus was rather sent for corpus callosum agenesis. And of course, there is corpus callosum agenesis in gestational week 27, but if you look at the posterior fossa, this is not normal, because here is pontocerebellar hypoplasia with a clearly disproportionate brainstem and a small vermis. And this fetus had a sibling later, and it turned out as a Vici syndrome with corpus callosum agenesis, abnormal gyration, and pontocerebellar hypoplasia. So this is a disorder of axon guidance. And if you have small vermian biometry and abnormal morphology, as you can see here, with the severe vermian hypoplasia, in both cases, then it might also be teratogenic. In both cases, there was in the first trimester, the mother had a vitamin A intake, a high vitamin A intake, leading to that malformation. And here you have the first case. And now look at it. Look at it. Look at this boy. He is really retarded in his movement and also a bit neuropsychologically retarded. And we are now collecting these cases, looking at the parts of the vermis that are hypoplastic, and of course also at the whole shape of the vermis, because we hope that we will become better with respect to prognostication when we know which parts of the vermis are missing to lead to certain neuropsychological outcome. If you have a reduced cerebellar diameter, you have to be aware the vermis and the cerebellum are different. And here we have a case in gestation week 21 who had a hemorrhage that reduced the size of the cerebellar hemisphere. But this is Sophie at 3 years. And you see her motoric development and also her intelligence is not impaired. So I think it is really important to look what part of the posterior fossa are involved and which parts are normal. Now, a reduced cerebellar diameter was already mentioned, and sometimes it is due to rhombencephalosynapsis when the two hemispheres are fused or almost fused, because there are also partial forms due to a missing or a partly missing of the vermis. And what we do here, we try to look at connectivity to be able perhaps in the future to tell more about the motoric function. And what you see here in yellow, the corticospinal tract is present here, and also some pontine tracts. Here you have the comparison 31 weeks and 1 year, and this is Jacob at 1 year, and he is rather intelligent, but he is motorically he is impaired. Well, the abnormal tectum, the so-called molar teeth. Gianluigi showed a lot of nice examples, and he said that it is maybe quite difficult to diagnose this in utero, and is completely right. But sometimes you are lucky, and here you have a collection of molar tooth malformations, and you can even distinguish between cow, cat, dog, and pig molar tooth. Well, this is just a joke. This is not yet scientifically, but I just wanted to show you that it is possible using MRI to find a molar tooth malformation. So what? Here you have an abnormal tectum. You see this really misshaped tectum, and proved by a postmortem specimen. The pons is flat and short. The cerebellum is too small, and there is also an encephalocele pointing towards the genetic background. When we do tractography, then we see that the tracts are not running as they should, because this molar teeth malformations are malformations of cortical guidance, so of axonal guidance. So the axons that form the corticospinal tract supratentorially just don't pass the pons as they should, and they run. They have aberrant connections somewhere, and then the function is impaired too. They are just misguided. And here we have another example of an interpeduncular heterotopia, and usually heterotopia are gray matter, but in this case, where we could also get a postmortem histological tensor study, it was shown that it was a white matter heterotopia. And so this little nodule is the corticospinal tract running where there should not even be a part of the brain. So here you have another example where tractography shows the aberrant path of the corticospinal tracts. Well, this was a publication already in 2005, just saying the physiological kink is present until gestational 15, and afterwards there should be not a kink anymore. If you suspect a kink after gestational week 15, you better get an MRI. Well, my last point is, what are we doing with MRI now? We are looking at myelination. You know, myelination, maturation of white matter, is the last step of brain maturation, and it usually takes, most of it takes place after birth. But in the brainstem myelinates already prenatally, and now we have found a method using MRI to show this myelination, seeing on the blue colors of the brainstem, and here you see the pathological specimen, and we can get myelination maps of the brainstem. The method is called MRI fingerprinting. It would take too long to explain that. So we think that maybe we will have another sign that we can use to evaluate posterior fossa malformations in looking at myelin at the brainstem. Here you have it at a little bit later at gestation week 31, where rather a lot of the brainstem is already myelinated and also parts of the cerebellar hemispheres. So please take home. MRI visualizes structures that may be less accessible to ultrasound, especially the brainstem and the vermis. And of course, I don't do that work alone. I have a huge team working at my hospital and also all over in the world doing that research. Thank you very much.
Daniela, thank you so much. What a fantastic, beautiful imaging-based lecture, not just showing us the power of MRI today, but also giving us an idea of where we are going in future. This is really, really outstanding. Daniela, we have a specific question on some of the technical aspects of the MR images that you're getting, one of which is what Tesla MRI system are you using to get such beautiful and clear images?
Well, we are using 1.5 as well as 3 Tesla. Resolution is better at 3 Tesla, that is clear. But sometimes 3 Tesla is more prone to motion artifacts. And especially if you have a small fetus where you would need higher resolution, it is better to be content using 1.5, because the modern 1.5 machines are also very good and you can get high resolution, and tractography is also possible there.
And Daniela, in many parts of the world, although MRI may be available, the expertise to obtain fetal images and also in particular to interpret the imaging is not there. Is there a system in place whereby images or MRI pictures can be remotely accessed by you, for example, members of your team, or are there such systems in place globally that can help those settings where, you know, it's easy enough to send a woman for an MRI, but getting that detailed reporting is just not there?
Well, yes, you are right. You are putting the finger really into a wound that we have because it's so difficult to, it is easy to put images into the internet and you can get access to all the teaching materials. But the problem is, for really getting good images, you have to sit at the machine and look how it is done. And I hope when we will be able, all of us will be able to travel, either we can invite more visiting fellows, because we always had fellows with us, and I think they were rather successful at home afterwards, or we can go somewhere and teach them.
Fantastic. Lots of questions. Oof. Gosh, where to start? Let me start with a simple one.
Could I ask a question, Iris?
About a cerebellum charts. I think probably the best one now to use is the one we've recently published on fetal cerebellar growth from the Intergrowth project. This is open access, available on UOG. It's freely available. We paid the publication charges for that reason. And the unique aspects of that study are that there's 3,000 or so images, but they're longitudinal. So they're from the same women over time is number one. And number two, the fetuses were then followed up into newborn, into the neonatal period. And those children have then been shown to be healthy at the age of 2 with normal growth and development. So this is, I think, pretty much a unique aspect of that study. There are many descriptive studies, but I don't think any other study has followed the children to 2 years in order to demonstrate that normal outcome. So I think it's not available on Viewpoint yet. Someone was asking about Viewpoint. I think it's partly because it's only just been published, but I'm sure it will come pretty soon. And perhaps Gianluigi, we can also ask some of these Viewpoint people to help us with that. Simon, please, you were going to mention something.
Yeah, if I could throw the cat amongst the pigeons and say that I think every patient who has a Blake's pouch cyst who has should have an amniocentesis. I think I first of all, just let me say that. Does everybody agree with that, or does everybody disagree with that? If I could just start with that as an opening premise. And maybe if I could ask that question to Gianluigi. If you do a scan at 18 to 20 weeks, you see a Blake's pouch cyst, you think the vermis looks absolutely plumb normal, the rest of the brain anatomy on good views is normal, and the rest of the anatomical survey, and she has a low risk on NIPT and a thin nuchal translucency at 12 to 13 weeks. Do you think this woman should be offered an amniocentesis?
But personally, I have a bias because I have a very low threshold for invasive procedure, because I think that invasive procedures are safe and there is a tangible risk of malformation. We should do them. The available data suggests that there is an increased risk of chromosomal aberration with Blake's pouch cyst, and we also have been surprised of having a completely normal cases that, was just looking perfectly normal on ultrasound, and yet there was a very bad pathological variance, copy number variance on the CGH. So in a way that is compatible, most likely 1% of our fetus will have a pathological copy number variance. But, in our own experience, there is certainly an indication for that. I may not be very objective because, again, I do not agree with all the fuss about invasive procedure. I understand that it's not a good idea to have them for patients that are more than just 35 years old. But if there is an abnormal ultrasound, I really do not see the point of refraining from doing a procedure. And the data suggests that with the Blake's pouch, there is an increased risk of chromosomal aberration.
I mean, it sounds like we're probably on the same page and there are no pigeons. But I think, if you told a woman she's a 1% chance of having Down syndrome, she would have an amniocentesis. And I think the problem, is broader, is more that seeing the French bottom sign on an axial section of the brain, the problem is that globally there aren't too many Gianluigis who can then assess the brain to say that it's normal. And then there's the issue of Daniela's very nicely demonstrated about the coexisting pontocerebellar hyperplasias, which in ultrasound are very difficult to detect. And then there's the new era of copy number variants, which if you do an OMIN search under Blake's pouch, you will get 28 hits covering 14 different chromosomes of deletions and duplications. So I think we're into a whole new world. And in a sense, Robert touched on this with his earlier question. We're in a whole new world of screening and diagnosis. But how much anxiety do we want to create? How far do we investigate? And in a sense, how do we find out what patients want? And it's a can of worms. But in the practical world, if tomorrow morning I go in and I see a Blake's pouch cyst, I know I'm no Gianluigi, but I'll try my best to see the rest of the brain. But I will still sit very uncomfortable without offering them a genetic test, even if they have an MR with Daniela, which shows a normal MR. But maybe Daniela, if you want to comment to that.
Well, I think exactly the same. Yes, as Gianluigi said, MRI is good, but all of us are not good enough.
Yeah. So
special problem situations where, like countries in India, we have got a termination law allowing only till 20 weeks. So whatever decision we have to give the couple is only till 20 weeks. In that case, if we have diagnosed something at 16 or 17 or 18 weeks, we can offer them this amniocentesis and rule out at least chromosomal defects and chromosomal malformation, and then we can counsel them that's how they need a possible follow-up with a normal MRI. So for situations in India or across the globe where there are some restrictions in termination of a pregnancy, some gestational age, there is a limitation. There is a definite role of doing invasive procedure, and that to do with a microarray rather than only pure karyotyping.
I mean, I guess the other comment is that it's not exactly the most prevalent condition. I mean, it's only a small number of patients that we are seeing coming through in specialist units with a French bottom sign and an axial section at the head. So, it's not like it's a 5% false positive rate where you're offering an amnio. So in a sense, that's another reason I feel I hold a low threshold. But I say that with, to throw it up for discussion, because I actually don't know what way I should go with these. And I'm just very interested in your collective opinions.
French bottom sign is interesting sign. New thing.
I mean, in some way, Simon, the issue you mentioned about non-trisomies, so all the extended genetic array that is possible now, it gives us the answer, isn't it? When we have such abnormalities that have been documented to be associated.
Yeah. I think, as I say, it's a brave new world, and if you look at it across chromosomes 7, 9, 3, 14, 17, sex chromosomes 19, 6p, 6q. I mean, there are so many different deletions, duplications have been described that I sit ill at ease. But it's a brave new world.
Wait for 2 years, more will come.
Yep.
More questions from Iris?
Iris, do you want to continue the question?
Simon, there was a question on how early one can do an MRI. Daniela, you showed some of these brilliant images, but sometimes you have a suspicion earlier. Do we need to wait until 20 weeks? Can we do MRI earlier? What are the concerns there, and what are the imaging limitations, if you like?
Well, we can do an MRI earlier. In Vienna, we usually do not start before 18 weeks for the brain, sometimes at 16 weeks, but before resolution of MRI is not good enough. Regardless which field strength you are using, ultrasound resolution is always much better. And so before gestation week 18, we cannot contribute a lot.
If I could ask Gianluigi, there's a question here, Gianluigi, that Blake's pouch cyst is in fact far more common than I'm suggesting. In fact, if you look closely at the mid-trimester, you'll find many patients have got a fourth ventricle communicating with the cisterna magna. At what point do you actually call that a Blake's pouch cyst?
In our experience, it seems that in completely normal fetuses, you can get an angle of up to 18 degrees. So we would call a Blake's pouch cyst if the angle is more than 18 degrees. That is internal, how we do it.
And do you have a rough idea of the prevalence, Gianluigi, off the top of your head, of in a population screen, how often you find a communication that's more than 18 degrees?
Well, I think if you struggle hard enough, you can find a communication in many cases, the impression of a communication, because if your angle is very steep, you can get the impression of a communication. I think that the real Blake's pouch cyst is not that frequent. I would rate that it is much less than 1 in 200, I think.
Yep.
We see more cases, but say more cases of mild ventriculomegaly than Blake's pouch cyst.
Yeah. The question that was asked earlier on, I think, is a relevant one, is to where do you actually place your two lines that intersect? How do you choose the point of intersection? Because sometimes that's very hard to see on ultrasound.
Well, there is, of course, some subjectivity into that. We look at the reproducibility, and it was rather reproducible in the upper angle.
Yeah. And are you a fan of 3D in this setting, Gianluigi, or are you just old-fashioned and go for the 2D?
No. I mean, maybe I did not point that enough, but I think that for the posterior fossa, 3D is fantastic. Mostly all because it allows you to do the scan in the exact place. Otherwise, you never know if you are exactly in the midline or slightly off. So I think that 3D is the best for the posterior fossa by far.
And thank you, Gianluigi. Daniela, if I can ask you, so you see a Blake's pouch cyst, or you're concerned about the possibility of vermian hyperplasia or Dandy Walker, and the scan's done at 20 weeks of gestation. Can I ask you about the timing of what is optimal? And I understand a lot of this relates to termination laws and gestational termination laws, but can I ask you, at what is the gestation that you feel there should be broad confidence? I know there will be Daniela prior as to where you feel comfortable, but where do you see globally in terms of a service provided by MRI and tertiary referral units that they should be able to confidently distinguish between these three entities with MR, or provide that additional information that we talked about with MR? What is the gestation?
Well, I think about gestation week 28 to 32, so gestation week 30, because then it should really be possible.
Okay. And in terms of those that persist, the 60% that persist, Gianluigi, we talked about the 40% that resolve. How do you counsel the patient who turns around and says to you, well, if I'm in the 60% that persist after birth, what can I expect?
Well, we do not know, because once these fetuses are assessed, have a magnetic resonance after birth, our neurologists and neuroradiologists do not believe that there is a need for further examinations. Just by chance, because some patients were over nervous about this, some of the patients had their infants doing magnetic resonance later on. And we know that in some of these cases, there is a regression even after birth.
Yeah. Okay. Can I ask a few questions? What could be the counseling to the couple if they have got a Dandy Walker malformation? What could be the counseling if there is vermian hypoplasia? What should I counsel to the couple that this is a possible outcome?
Are you asking me?
Yes, sir.
Well, you have to remember one thing. I mean, I think that there is misjudgment around the world, because I am a gynecologist who is performing ultrasound. So and I try to be as effective as I can. That is, I try to identify malformation. I believe that when you have identified the malformation, or a case that is a very high risk for malformation, this is such a delicate matter that it deserves all the possible expertise. So whenever we have a malformation that is not obvious, let's say an encephaly, just to make an example, holoprosencephaly, then we would refer the patient for an MR. And then if there is something which is not obvious, we have a consultation with a neonatal neuropediatrician, because I think that this is a work for professionals. I am a gynecologist and I am an amateur. I have limited knowledge of all these things, despite the fact that I have been working on this for a long period of time. So I think that if it is a professional doing the counseling with me there, because I feel that I am an advocate for the mother, and it's important for us to be there. It is just the same with cardiac anomalies. I mean, how do you counsel now a patient that has a fetus hypoplastic left heart syndrome? How can you explain the many details and differences that you have? You need a professional. So I think that this is a multidisciplinary field.
Okay, so we don't counsel like that this is the percentage where there are going to be a possible chromosomal defects. These are the percentage where you will have neurodevelopmental delay, or this is how the possible chances of cerebral palsy in this fetus.
Well, of course, when you identify a patient that has a malformation that is not obvious, that requires further investigation, then you bring in the subject of an invasive procedure. And we have genetic people that work with us, because you have seen, Daniela has clearly presented which are the many infinite possibilities of other type of diseases that you have never heard of, difficult syndrome, congenital abnormalities of metabolism, all of these. So as I said you again, this is really a multidisciplinary field. Then, from my point of view, what I think is important is that you need to have a detailed picture of the situation that is as detailed as possible. And I am strongly in favor of invasive procedure in any case in which there is a suspicion that there may be a problem. Invasive procedures are safe. It seems now that they are like hell. I don't know why we have created this situation.
I totally agree.
If I could ask you a question, Daniela, if I could ask you a question. There has been some controversy in recent years about the routine use of MR in the setting of a finding of either mild ventriculomegaly or posterior fossa. Do you feel that all patients where you find a posterior fossa where there's anti-clockwise rotation of more than 18 degrees with the keyhole deformity on axial imaging, do you believe these should all be offered MR?
Well, in Vienna, yes.
Okay.
Well,
depends where you are.
Yes, I think so. If you neuroradiologists have some experience and are used to answer these questions, I think yes, you should get an MRI in any of these cases.
So you're saying, in a sense, it reflects more to do with what the standard is of the ultrasound imaging or the quality of the ultrasound imaging. It's a balance between when you bring MR.
It always
into the
is.
picture.
Yes, it always is.
But if you assume, and this is in a sense where the debate comes in, if you assume that you have high quality ultrasound, is there a role for routine MR in a setting of a posterior fossa anomaly, query Blake's pouch? Just a broad opinion. Do you think it's still in your experience?
I think at the moment it is, because at the moment just both modalities can really contribute more than one modality only. Even if you have good conditions, sometimes it's just a question of modality and not the level of ultrasound.
Yeah. If I could ask just one closing question to you, Daniela, is with regard to false positives in MR, we know about ultrasound because ultimately, after the patient leaves us, they go on for intensive investigation and imaging, and we hear about it when we don't get a diagnosis right, because they're in the chain of investigations. Is there anything with regard to MR about making a false positive call on seeing something in MR, either in terms of measurement or qualitative assessment of the posterior fossa, that you might have concerns about that you could share with us?
Of course, always. And just to confess, when we get a patient between gestation week 80 and 24, we almost always call her back later because sometimes the course can help you to decide whether it's false positive or it's something you really saw.
Yeah. Thanks, Daniela. Are there any questions from anybody else? Prashant.
There are some questions here I can see from the question list.
I'm just mindful of the time, that's all. Yeah.
Yeah, okay. The last question I'll ask. How to suspect cerebellar vermis hypoplasia in case when there is closed fourth ventricle in second trimester, to Janila ji?
Prashant, I couldn't understand you.
Okay, I'll repeat. How will you suspect the cerebellar vermian hypoplasia in case when there is a closed fourth ventricle in second trimester? For Janluji?
Yes.
And closed fourth ventricle. That's what the question is. Which is practically not possible.
Well, yes, that's why I'm wondering.
I was looking forward to the answer.
Of course, we will do all our measurements and look whether it's really true. Or perhaps there is a misconception and there is another malformation present.
Okay. Any comments, sir?
No, I think we better let Daniela and Gianluigi go. It's been a long session and an absolutely fantastic webinar. Thank you very much for your time.
Thank you.
It's greatly appreciated by all of us, and look forward to seeing you again soon. And for everybody who's joined us around the globe, there's over 3,200, and I don't know how many have signed in from China, but a fantastic turnout, which is a testimony to the standard of the speakers that we've had joining Scan Academy this evening. 40, okay. So,
Simon, can I just briefly apologize?
There you are,
very briefly. Yes, I've had some connection problems, but I just really wanted to thank so much Gianluigi and Daniela for joining us today. It's been such a pleasure, and we've read out the questions, but what we haven't read out is the many, many, many compliments on the superb talks today from all the speakers. Really, really brilliant. So thank you so much. And it's such a nice feeling to be able to get together as colleagues and friends, especially as many of our countries are locking down for the second time and looking towards the second wave of a pandemic. So I'm hoping that we're able to continue this. We've got lots of ideas on future programs on facial anomalies and urinary anomalies and many others. If you have any specific ideas from the audience, please, specific requests, please send them to us. We're always happy to hear from you. I just wanted to say a big thank you, really. Simon, I'll let you close since you've been sharing the Q&A.
Thanks, Iris.
Thank you, Daniela. Thank you, Daniela, and thank you, Gianluigi. This is typically Indian style to say thank you to both of you, and by joining the hands together. So thank you very much. That's called we call it as a namaste. So thank you and namaste from India and all the colleagues.
Thank you, Prashant. Thank you, Daniela and Gianluigi, and stay safe. Goodbye, everybody.
Bye.
Thank you.
Bye-bye.
Goodbye. Great session. Thank you very much for inviting me.
Thank you.
Thank you.
Thank